Okay, all right. So since Vikas came on, no, first Nikhil came on first. So Nikhil, your baby, okay?
Yes, sir.
So can you see the screen?
Yes, sir, I can see.
Yes, sir.
Nikhil, tell me indications for insertion of chest drive. Give me some indications for insertion of chest drive.
Pleural fluid, hemothorax, pneumothorax, large.
One by one. Go slow. Don't be in a rush. Okay. So you said pneumothorax. Okay, good. I accept that. What else?
Hemothorax, pleural effusion.
Okay. All right.
Hemothorax in pleural effusion, hemothorax, chylothorax,
Yeah.
empyema, pus, and in case of esophageal rupture.
So what about esophageal rupture?
Post-operative.
Okay. All right. All right. Okay. Now, Vikas, come in.
Yes, sir.
What are emergency indications for ICD?
Any patient with tension pneumothorax, it's an emergency.
So what sort of clinical situations? Give me some clinical situations where you get that.
A traumatic pneumothorax.
Okay.
Which is turning into tension pneumothorax. Massive pneumothorax, which is causing any respiratory distress. We need to put chest tube.
Okay.
These two are emergency indications for intercostal drain.
Where else? Where else will you rush in and put in pneumothorax? Emergency ICD. Where else will you rush in? Now, let me just tell everybody, okay, this is the most commonest topic in the exam. Okay, I promise you this. Somewhere along the way, you will be asked these questions, okay? And if you make a mistake in these questions, not a mistake, but if you don't do well in these questions, you lose points because this is the most basic of it. So they really want you to crack this. This is the question we ask you when we want you to come up to the passing grade. Okay. So we want you to come out to passing grade. So we start off with ICDs and things like that. Simple things. Okay. So emergency ICDs. You told me trauma. I agree with you. You told me large pneumothorax. I agree with you. Where else?
Tension pneumothorax.
Yeah. Where else? Tension pneumothorax in what clinical situation?
Pardon?
In your clinical practice, where will you see tension pneumothorax? Where are you worried really fast?
Particularly open sucking wounds.
Okay. What else? Open sucking wounds are not a problem. They are open. So. Okay. Open sucking wounds. I'll give it to you. What else? What else? I'm not saying no to everything that you're saying. What else?
Yes, sir.
More things. Give me more things.
A foreign body can also sometimes lead to situations where we have tension pneumothorax.
Which is the commonest indication for putting in ICDs in the ICU?
Suppose the patient is on ventilator. We did
mechanical ventilation.
CPAP. I'm putting on CPAP.
Okay.
Positive pressure ventilation.
First indication.
CPAP.
Okay. Mechanical ventilator. Okay.
Mechanical.
Agreed or no?
Yes, sir.
Yes,
sir.
Everything else is okay, but mechanical ventilation is where the moment, even if he's got a small pneumothorax, you very quickly go and put in a chest drain. Okay. Large pneumothorax, completely agree with you. Tension pneumothorax, completely agree with you. Clinically unstable, completely agree with you. Blunt or penetrating chest injury, agree with you. Where else? What else? Some more indications for emergency ICD.
Large effusion causing hemodynamic instability.
We said that.
Hemothorax.
Massive hemothorax. Massive hemothorax.
Hemothorax.
Massive hemotherma.
Anybody who's transporting by air, okay? Most
Okay.
important. Okay, you have to very quickly put in an ICD. Agreed? Okay.
Yes, sir.
Hemopneumothorax. Agreed?
Yes,
Yes,
sir.
sir.
Hemothorax. Agreed?
Yes, sir.
Yes, sir.
Yes, sir.
Bronchopleural fistula, where they are losing all the volume on one side. Yeah.
Yes.
Yes.
And an emergency esophageal rupture with pleural contamination.
Full contamination.
Okay. The first thing you want to do is put in
Okay.
a chest drain. Okay. These are all
Chest
emergency. These are all emergency ICDs. Okay. I'm just going to go back and revise everything. Okay. This is important. You must know all these. Huh? This is straight from the examiner's guidebook. Okay. So everything I'm telling you is there. Mechanical ventilation, large pneumothorax, tension pneumothorax, clinically unstable patient. You should never have a chest X-ray showing a pneumothorax. Blunt and penetrating chest injury. In cases of any patient who is being transported by air, in patients who have hemopneumothorax, patients who have giant hemothorax, massive hemothorax, patients with acute rupture of bronchopleural fistula and gradually losing all volume, esophageal rupture
And
with
esophageal
pleural
rupture.
contamination. Okay, these are the ones which are emergency ICDs. Agreed or no?
Yes, sir.
Sir.
Okay.
Sir,
Yeah, go on.
sir, for airlifting is for only a patient or any patient?
Spontaneous pneumonia.
Yeah, somebody who's got some pneumothorax, you must put in a chest drain before you
Spontaneous.
transfer the patient. Any patient with pneumothorax
No.
should not travel without a chest drain. Okay, that's the bottom line. Okay, not for all patients, but any patient with even a small pneumothorax should have a chest drain if he's going by air. Why? Okay, Nikhil,
may
tell me why.
The pneumo will increase.
How?
Spontaneous rupture.
No. What
Abolition
is
of the negative interruption.
Pressure in the
Pressure
air
inside the flight.
Yeah, what is
will
the
be-
pressure in the flight? What do you mean by that? Use the proper medical term.
Sir, because the
The pressure
atmospheric
is
pressure
low.
is
What
equal
pressure
to
is low? What is it called as?
Atmospheric
Pressure
pressure.
is atmospheric.
atmospheric pressure is equal to intrapleural pressure, sir.
It's not
Equivalent
equal
to
to
interpleural.
Yeah, it's not equivalent, but moment you have reduction of atmospheric pressure, there is a change in the interpleural pressure, and the change in the interpleural pressure causes rapid rise of a pneumothorax within the pleura. Okay, so a simple pneumothorax can become a tension pneumothorax. Hence, you have to always put in a chest drain. They will never let you on a flight with a chest X-ray showing a small pneumothorax without an ICD. That's the reality. Okay. Okay. Next question. Whoever wants to come in, I don't know who is on the call, but Fitun, if you're on the call, you can take this. Okay, Fitun is not on the call. Who else is on the call? Let me see who else is on the call. Vivek, I saw. Sri Hari is on the call. Vivek,
Yes, sir.
give me some indications for this thing. Again, I'm not picking exam going or whatever. I'm just whoever I
Yes,
want to get the discussion going. Yeah. Give me some indications for elective ICDs.
Sir, hydropneumothorax.
Start with simple things. No? First thing is what? Empyema, happy with that?
Yes, sir.
Empyema. Start with simple things. No, empyema is the first thing where you put in it's an elective ICD. Yeah.
Yes,
What
sir.
else? Come on, Vivek, this is
Moderate
your
pleural
everyday
effusion.
game. Okay.
Small
Clinically
or moderate.
significant.
Yes.
Clinically significant pleural effusion. Agreed. Completely agreed.
Yeah.
What else? Everyday practice. Where else do you put in chest
Post-op.
drain? Very good. Post-surgical effusion. Very good. Where else do you put chest drains? Elective ICDs.
Chylothorax.
Cardiac surgery, sir. Cardiac surgery.
Okay. That is
CABGs.
post-surgical. Post-surgical. Yeah.
Okay.
What else? Come on. Common things you see every day in your life, man.
Surgery on diaphragm.
अरे यार पहले कॉमन
Post-op.
बोलो यार प्लीज यार सिंपल
वो
कॉमन
भी post surgical है.
Chest trauma.
okay trauma is
Chylothorax.
okay I'm happy with trauma before that where do you
Chylothorax.
see it do you see it on the
Chylothorax.
oncology or what malignant
Malignant
pleural
pleural
effusion
Malignant pleural.
yeah this is the way
Yes.
you get stuck in the exam when you're talking okay malignant pleural effusion is an everyday event okay all right so and somewhere where you want to give sclerosing agent or pleural disease the others are of course recurrent pleural effusion parapneumonic effusions chylothorax post cardiac thoracic surgery I agree with everything what you're saying But what I'd like to see is everything coming out really fast. Okay. So now I'm going to go back and somebody's going to tell me all bang, 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 bang. That's the way you have to practice. Okay. Come on. Vivek, you can still take it.
Yes, sir. Clinically significant pleural effusion, empyema, then post-surgical drains, and post-surgical effusion, malignant pleural effusion, and yes, sir, pleurodesis. Recurrent pleural effusion, malignant pleural effusion, empyema, paranemonic effusion, and chylothorax. Post-surgery, yes, sir.
Okay, this is okay. It's very straightforward. But what I want you to practice is it should come. If I put you on the spot, it should come out. You shouldn't struggle. Okay, I know you know it, but don't make me bring it out. You come out with it. Okay. All right. Yes, sir. Shilpa on the line. Do we have Shilpa today with us or no?
Yes, sir.
Yes, sir.
Shilpa, take this.
Multiple ICDs, post-surgical, post-esophagectomy, then mediastinitis.
Yeah.
Mediastinitis.
Good,
you may require
keep going. You're doing very well.
Bilateral post-traumatic pneumothoracis, bilateral pneumothoracis. Okay. Then pleural effusion, bilateral pleural effusions, some malignant effusions which are on the both
so
sides.
Loculated effusions, okay?
Yes.
Loculated effusions where you have one in the top, one in the bottom. Previously poorly positioned existing drain. Okay. You agree with that when you have a drain which is not draining very well? In a high flow bronchopleural fistula, and post surgery. Everything that you said is all agreeable. Okay. So absolutely happy with that. Well done, Shilpa. Okay. Bhushan, are you there?
Yes.
Take this.
Contraindications for ICD. A large emphysematous bulla occupying a majority of the hemithorax.
Okay. Good. Well done. बोलो ना और contraindications.
Tracheobronchial disruption. Anything which is which will prevent tamponade, major vascular injury, trauma, penetrating chest trauma where major vascular injury which will
release the tamponade.
Release the tamponade.
Okay, let me just come back with this. Okay, there are two absolute contraindications. One is
dissection. Coagulopathy.
Aortic dissection.
Coagulopathy. I like that. Dissection. Why is that a contraindication?
It's a contained rupture or something. So if it's a contained rupture,
okay. So you're talking
only for
about
contained.
Okay.
Yes.
All right.
The diaphragmatic hernia.
Why is it a contraindication?
It's not absolute.
It's a relative contraindication. Okay.
Relative.
Right. Okay. So let's go through it. First and foremost, if you need to open the chest, don't waste time putting in chest tubes. Okay. And the second absolute contraindication is the one which Bhushan said very first, is pleural adhesions at the site of insertion or a large giant bulla. Okay. You cannot put in chest drains in these two situations where you actually have to salvage the patient. Okay. And everything else is relative contraindication. The one thing which you didn't tell me is infection at the site of insertion.
Okay.
Okay. So infection is not a good, never go through infective areas. Coagulopathy is completely acceptable. I like that. Emphysematous bulla, which you told me again. Well done. Loculated effusion is actually a relative contraindication. You can get it. They are talking about the medial effusion, which is next to the heart, things like that. You can't put in a chest tube because it's very far away from the skin. And then I like the hernia part where you said diaphragmatic hernia. I'm quite happy with this. And the other thing is, if it's a hepatic hydrothorax, then you have to treat the lung you have to treat the liver rather than the lung. And if you put in a chest tube, you're stuck with the chest tube and it just keeps draining continuously. So that's why you have to be a little careful about putting in chest drains in hepatic hydrothorax. Okay. You have to treat the lung rather than the you have to treat the liver rather than the lung. Unless he's compromised, then you put in a chest tube. Otherwise, try not to put in chest tubes. Otherwise, you'll never get rid of the chest tube. Okay, that's the problem. All right.
Sir,
So one doubt. Okay.
Yeah, sure. Who wants to ask the doubt?
So, is a contraindication also like consolidation with the air bronchogram?
Not really, no. In consolidations, if you got empyema and pleural effusions, you do put in a chest tube.
Okay.
But you shouldn't put in a chest tube into the consolidation. Do you know what I mean?
Okay.
Sir, I also had a question.
Yeah, sure. Who's that? Kriti?
Sir, in esophageal rupture, why do we put a drain in the pleural space?
Because the esophageal rupture usually ruptures into the pleural space and it causes contamination with bacteria. The bacteria in the esophagus is different and the pleural space is sterile. So the moment the esophagus ruptures into the pleural space, there is contamination by the bacteria and then you get empyema. So very, very high risk of getting empyema. Okay. So that's why you always want to drain. You want to drain the pleural space. The bugs in the GIT are not present in the pleural space. So the moment the esophagus opens into the pleural space, you get severe empyema. And so you really have to put in a chest tube. Okay.
Thank you, sir.
Sir,
which I never done, but as suggested, do you insert a ICD from the same hole, the previous ICD site?
Usually never, ever put it in the same hole. Always go into another hole. Okay. Never, ever put it into the same hole. That's my
nice
philosophy.
question.
You know it, Nikhil.
Yes, sir. I know it.
Never, ever put it in the same hole. Never, ever. You will cause empyema. That's very bad because the moment you push it through the same hole, it's an infected hole. So the bugs will get into the pleural space and you will have empyema. So never ever do that. Unless you're on table and you're doing it, and that's different. You know, on table you are under sterile conditions, you have debrided the. That's a different situation. But in normal life, in everyday practice, as a routine, general surgical practice or a thoracic surgical practice, never ever put in an ICD through the same hole. Okay. No matter how much antibiotic prophylaxis you give, you're exposing the patient to a risk of empyema. Simple problem will get converted into a very complex problem. Okay, come with me now. Who wants to take this? Who is there? I can't see who's there. Let me just let me bring up who's there.
Ramaswamy is there.
Ramaswamy, you want to take this? Ramaswamy, this is good. I like this. Ramaswamy, tell me about what are you going to do for ICD consent?
Informed consent, informed valid consent needs to be taken from the patient, sir.
Okay. So now my question is going to come back to you. What is an informed valid consent?
The procedure will be explained to the patient in his own language. Either the person who's going to do the procedure or equally qualified person who has already done the procedure will be explaining the patient, sir.
Okay.
Yes. And the patient should be so I'm not able to recollect the points.
Come on, this is the whole practice. This is why I'm putting you on the spot. The idea of putting you on the spot is that everybody knows you know it. But we want to put you under pressure to see if you can reproduce under pressure. You understand that? So nobody's judging you, Ramaswamy.
Yeah,
don't worry.
Yeah.
Nobody's judging you. We're just putting you under pressure.
Okay.
You do this every day of your life. So you should be able to reproduce this really quickly when you come under pressure. Exams are all precious.
Okay. Yeah.
So I agree with the language part. I agree with the explaining the procedure by a person who has done it. What else? What else constitutes an informed valid consent? There are two words there. There is an informed and there is a valid, and you have to explain both the words to me.
Yes. Sir, the patient should be in the right mentation. So like he should...
Absolutely correct. So patient should be compos mentis, mentally stable.
Mentis. Yes.
Yeah, mentally stable and of adult.
Of adult, yes.
Adult age, okay. Yes. Yeah. Pediatric consent comes from a different route. Okay. What else? What else? It's okay to be on the spot, Ramaswamy. I'm really genuinely not trying to put you down. I want you to feel the pressure.
Yes.
Otherwise, it's easy for me to ask somebody else to come in, but I want you to feel the pressure.
Okay. So the concern should not be the duration of the consent should be within 24 hours.
Good. Well done. What else?
Yes.
Well done. Very well done. What else? Okay, I will ask you one question. Okay, one question I'll ask you, a direct question.
Okay.
Say there is a guy and his son signs the consent saying, I am, the responsible person for the house. Is that a valid consent?
No, sir. No. It's not a
completely
valid
invalid.
consent. It's a invalid consent unless
good.
it is going
So
to be an emergency.
Even in an emergency, is a relative's consent a valid consent?
No, sir. The decision has to be taken by the physician or the treating surgeon.
So in an emergency, who will give
Patient.
If a patient cannot give consent, who should give consent? Legal. Who should give consent?
Sir, equally qualified. The decision has to be taken by an equally qualified surgeon.
So one person or two persons?
Two persons, sir. Two persons.
So 2%. Two physicians.
Yeah, two physicians.
Okay, two physicians of independent inquiry, independent level.
Yes.
Okay, what else? What else? In an emergency, who else can give consent? In a child, in an emergency, who else can give consent? If the parents are refusing to give consent and the patient's life needs to be saved, who can give consent?
Can I take?
I'm not talking about ICD. I'm talking about any procedure. Okay.
Okay. Okay.
So can I take the?
1 minute. Wait.
I'm not aware of the designation, sir. But is it the medical superintendent?
No. Medical superintendent cannot. The medical superintendent can sign as two physicians.
Okay.
But in a child situation where the parents are not willing to give consent, who should give the consent? Okay, Nikhil, you take this question.
Yeah.
Treating two physician pediatricians.
Yeah, even more important than that. The court, okay, you've got to get a magistrate to give the consent. If either two treating pediatricians or physicians, or one treating physician and one medical superintendent, but the court must be informed, okay? And you must get an emergency consent from the court. It is mandatory, okay? These are all highly medical legal areas where you've got to be very, very careful, okay? So at least in the UK, it's the court or the magistrate who can give consent, okay? Now I'm going to ask another question, okay? Nikhil, you want to stay on or Bhushan, come in? Bhushan, FRCS, yes, no? FRCS, Bhushan, come in. Bhushan, are you there or no? Vikas, come in. Kya hua? Are you there?
Yes, sir. Yes, sir. I'm there, sir.
Vikas, what is Gillick consent?
Gillick consent is it was related to incidents where a 12-year-old child was involved, sir. So Gillick consent is a person is on honor of his own body, so he can decide what is good for him. Kind of.
Yeah. So it is 12 to 16. Okay. Any child who is able to make a decision for themselves, not 12, it's 14 to 16. And if a patient feels that he can make a reasonable decision for his own body, then he is allowed to give a consent in spite of his parents not agreeing to give a consent. Okay. That is called as Gillick consent. It is a case which was in the courts of the UK. Around the world, this case has been agreed. So it's very important. Okay. Consent is very important. You must get it correct.
So in every case?
Not in every case. Only in specific cases. But if a child is deemed to be adult, as in from 14 to 16, then he can actually consent. And this can be backed up by the court or the magistrate. We have to get courts or magistrates involved in this. But of course, if it's an urgent life-saving procedure and you don't have time to take anybody's consent, then 2 physicians can take it. But good clinical practice is to get the magistrate to give consent. Okay? Always the court should be involved, much better, so that you don't get into trouble. Okay. So what are the criteria for a consent, for a basic consent? Now we've spoken about advanced consent. Tell me the criteria for a basic consent. Anybody can take it. Who wants to
So
take
I can
it?
take Anuj here, sir.
Anuj, take the
Yes, sir.
criteria for a basic consent. Come on, quickly.
So first we have to explain to the patient in vernacular language the indications of the why we are
Fantastic.
putting the ICD. Then,
Well done.
we have
And what else you have to explain?
Then whether it is what is the, like, is it an emergency or it is a routine? Then we have to explain the procedure, like it will be local anesthesia or general anesthesia or in ICU setup, and how is the duration of the procedure. Then we have to tell about, sir, pros and cons of the procedure.
Very
like
good.
What can go wrong in that, risk and complications
are very important. Risks and complications have to be explained and documented.
Documented, sir. Then
What
other
else?
thing, we have to tell about other treatment options if possible for that procedure, sir. That
Very
also
good.
has to be
Excellent.
told to them.
Alternative options are okay. So in an ICD consent, what specifically you'll talk to the patient? Risks and complications?
Yes, sir. First, sir, depending whether it's for hemothorax or pneumothorax, so we have to tell about, like, because we are giving local anesthesia, there can be reaction to that. Then we have to explain about pain. Patient may have prolonged pain. Then injury may be there. Patient may have bleeding or this thing risk we have to explain. But we have to balance that with the, like, advantages of the procedure, that it is a life-saving procedure.
Switch it. Very good.
Then yes, sir. Then other, like, there will be re-expansion pulmonary edema. That thing we have to explain. May need
It's
a ventilation
important.
also.
Why pulmonary edema becomes important in an ICD?
So because re-expansion pulmonary edema, sir. If
so why does it become important to explain to the
because patient may need require ventilation, sir.
Very good. It may need to go to ICU and ventilation.
ICU.
Okay. That is why it's very important. So pain, pulmonary edema are very important to be explained. What else?
So then we have to, like, explain them. It may be a prolonged duration, like how much duration will keep the ICD. Sometimes patient do ask.
Yeah.
Like
Very
it will
good.
be, because
Excellent.
it's a malignancy, it may stay for long duration also.
Excellent.
And this
what
is
else you
not,
have to explain?
Then we have to tell them it's not the treatment, like it is just we are resolving the condition only. We are not treating the main cause. Main cause may stay there and we may have to further treat the main cause. It like it's a malignancy.
What else
or something.
you have to explain? Tell me important, really important stuff that you have to explain in an ICD.
Bleeding.
Bleeding, re-exploration. Yes, sir. We may have to open change to the,
not re-exploration, lung injury.
Lung injury, yes, sir. Lung injury, diaphragmatic
we have
injury.
to talk about cardiac or great
liver
vessel injuries.
Yeah,
injuries to other surrounding structures.
Yes.
And what else
then
you have to explain to the patient?
Risk of infection also, sir. May, like, later complications.
Very important. What else? What else you have to explain to the patient?
Requirement of blood also we have to tell them. So it may.
You have spoken about the morbidity of the operation. I agree.
Yes,
what
sir.
Else you have to tell the patient?
Mortality.
Thank you very much. God bless
mortality.
You. Well done. Okay, you have to tell everything.
Mortality.
There is no hiding from the patient. You have to tell. There's less than 1% risk of mortality, but when you puncture the heart, patients die. Okay.
Die.
So don't think that it is just a simple ICD. Okay. You have to explain everything to the patient. Somebody take this question. Next guy take this question. What are late complications of ICD? What else you have to explain to the patient? Kriti, you can take it if you want.
Yes, sir.
Just take this. What else late complications you have to explain to the patient? You put in an ICD. What can go wrong?
Infection.
Okay, good. Very good. When the tube gets blocked, then you need to put in a second tube. Yeah, so you have to explain that. The tube could get blocked. You might need to put in a second tube. You told me about wound infection. I'm okay with that. What else? Late complications. The drain is in the chest wall for a long time.
Sorry?
The drain is in the chest wall for a little while. What can happen?
Sinus
emphysema. Rupture. Sorry?
You keep talking, Kriti. Don't listen to anybody else. You just keep trying to think. What else can happen if the chest drain is in the chest wall for a long time? After infection, what else can happen? You can get empyema. Good. What else can happen? You can get bleeding from intercostal vessels. Because of chronic pressure, you might have a rupture of the intercostal vessels. What else can you get? Chronic, what else can you get?
Subcutaneous emphysema.
Yeah, more than that, what else can you get, which you have to explain to the patient? After the chest drain comes out, what? Sorry, who said that? Somebody said something now.
Chronic pain.
Chronic pain.
Chronic pain. Very good. Excellent. Excellent. I like that. Okay. Very important. So all these have to be discussed. Everything that you guys said, each one of you was correct. But this has to come out as a single person talking all the indications. 1, 2, 3, 4, 5, 6, 7, 8. Okay. It should not be a joint effort. It should be, you know, one person being able to come out with everything. I don't mind even
And
if
there
you
be a
reproduce.
dislodging.
Yeah, dislodgement is possible. Yeah. Tube kinking, blocking, dislodgement is all part of the same thing. So you have to consent for a repeat ICD as well. Okay. Okay. So continue with the consent. We said something. We said legally should be capable of consent. Agreed? We said the patient, the consent should be informed. Yeah. That means you have to discuss the risks, pros and cons. The consent must be specific only for that procedure. You cannot do anything more than what is asked for. Okay. You cannot do a second procedure if you have consented for one procedure. This is important. The consent should be given of own free will. Okay. That is an informed consent where the patient has given the consent, not the relative. Okay. And the consent must cover what is actually being done. Okay. You cannot generally say that I'm going to do something to the chest wall. You have to actually talk about specific things. Okay. It's got to be very, very specific. Achha, what are the patient factors for a consent? Come on, quickly. What are the patient factors? Language, somebody told me. Very good. I like that. What else?
Mental corporate.
Mental
Yeah, okay. So he's able to appreciate the situation. So he's compass mentis. Good. And he's able to understand in a rational fashion. Okay. And he's able to make a rational decision. This is important. And more importantly, the patient should be able to communicate the choice to you. Okay. These are 5 factors which go to form a patient side of an informed, valid consent. So the informed part is all the other things that you told me, and a valid consent is the patient factors. So when we talk about an informed, valid consent, we're talking about informed is where the doctor tells everything to the patient, and the valid part is where the patient fulfills all the criteria, and then the consent is the signature. Is an oral consent okay?
No, sir.
No, sir.
Usually
Yes,
in the court of laws,
should be written better.
in the court of laws, ideally it should be a written consent, but sometimes the patient may not be able to sign. Then the oral consent is valid provided it is witnessed. Okay, witnessed by 2 people. That is what the law says. Okay. All right. Let's go to the procedure. Somebody explain the procedure. Who wants to come in quickly? Who is there?
Yeah,
Fitun,
I can come
are
in,
you
sir.
there? Who is there? Who is that? Who said I can come
I'm
in?
here. I'm Fitun, sir. Yeah.
Fitun, okay. Fitun, take it.
Yeah.
Just tell me explain the ICD procedure to me. What are the, before starting the ICD, what are you going to make sure?
That's explaining to the patient or explaining medically?
We've done that. We've done all of that. We've explained. You're about to put in an ICD, but before that, tell me, how will you prepare for the ICD?
Okay, so it depends whether we are doing it for a child or for adult, as in it depends whether we are in the OT, doing it under anesthesia or sedation, or in the ICU, or we are just in the emergency room. Then we have to ensure we have a sterile environment. So we need to prepare, disinfect
I'm
the
happy with that.
skin.
Okay. I'm happy. You have to make sure that you have got appropriate sterile equipment with trays. What else do you need?
And then disinfection of the preparation of the site where we want to put the chest.
Before we do the site, tell me what you have to make sure.
Okay, so we need to
We're
make
not
sure.
touched the patient as yet. What have you got to make sure?
We need to make sure of the instruments that we have.
We've done that.
Okay. Yeah,
we did
it's
that.
already charged.
What is the next thing you want to make sure? You
I
need to
show
make
it
sure
on
you've got a skilled assistant.
Yes.
What else do you need to make sure?
Before touching the patient.
Side.
Say ECG, oxygen.
Very good.
You need
I
to
like
have the
that.
patient to have
Monitoring.
an IV cannula. Yeah, monitoring equipment.
You have to make sure that the monitoring is in place. Okay.
Yes.
What else have you got to make sure?
Coagulation profile.
Oxygen.
Yeah, we've seen all that.
PDI,
We're talking about, yeah. Okay. So you look at the
Side.
blood test and investigations.
Test,
And what else in terms of
Which
patient
side?
comfort? Anything you need to make sure about patient comfort?
Patient
Positioning of
position
patient.
and
Yeah. So
side.
the patient is adequately positioned. Yeah. You have to make sure that the positioning of the patient is comfortable. He's not sitting in an awkward position for a long time. Okay.
Yes.
What else you have to make sure? Before you start the procedure.
Analgesia.
Okay. Good.
If
Well
we
done.
need to give sedation or analgesia, yes.
Excellent. So you got to make sure that your pre-medication is there if you need to give. You have to make sure all your anesthetic is there. You have to make sure sedation is available. Okay. What
Even
else you
for
have to make
adults,
sure?
Shall we say
Adult,
this even
whatever.
for adults?
Yeah. This is all
Yeah.
for all patients.
All.
Okay.
What else? This is basic for all patients. What else you have to make sure?
Oxygen.
What is the
Flashing
guidelines
shooting
say? What does the
monitoring, right?
guidelines say?
Which
What is the
side?
one thing you have to use? Side is marked.
Mark
Well
the
done.
side. Side to
It
Well
is-
done. What else?
Must
It
be
has-
confirmed
X-ray
with an
should be-
X-ray, chest
X-ray should be
X-ray,
next.
and done under ultrasound guidance then and there.
Thank you. God bless you. Whoever said
Ultrasound
that.
guidance.
ultrasound.
Because
Okay.
well done.
Recommendations.
Make sure that ultrasound is available. Okay. You have to make sure. This is part of the guidelines. You should not put in chest drains without ultrasound guidance. Nowadays, it is nice guidelines. So if you're going for FRCS exams, I know you do this. Don't do this in your country. Whoever, whatever countries, you may not do it. But if you're going for FRCS exam, you have to go by nice guidelines. And nice guidelines says you should not put in chest drains without ultrasound. So you have to make sure that an ultrasound machine is available. And more
you have
importantly,
to know how to use it yourself, right?
yeah, you have to use it yourself. More importantly, what else you have to make sure? How do you make sure that you have put in the chest X-ray in the correct place?
So ultrasound has to be done while doing a procedure. We cannot get
Okay,
it
but
marked
how
in
do
the
you make sure
department.
it is there in the correct place?
You mean we have to have the X-ray on
Identity, patient
Yeah, so
identity.
X-ray should be there. Okay, X-ray. Radiology should be available. Okay, radiology should be available. Now tell me all about sizes of chest drains that you know of.
Okay, so size, choosing the sizes depend on the pathology or on the cause why we are putting the chest drain for.
Okay.
So let's say if it is simple pneumothorax, then we don't need to use large chest drains.
Yeah.
If we are doing it for empyema or fusion, then it is better to use larger chest drains.
So give me numbers. Give me numbers. This is FRCS exam. So we're not talking general. Give me numbers. Give me what size for a simple pneumothorax.
So it depends on the body build, again, on the body build weight of the patient.
14
So
French.
if you are talking about an adult patient of whatever size.
Fitun, 1 minute. Fitun, all exam is about adult. This is not about pediatric exam, okay? So stick to adult. I know you do pediatrics, but in the FRCS exam, just talk adult. Don't talk pediatric, okay? People don't know much about pediatric. Just stick to adult. So what size? If you've got a pneumothorax, small pneumothorax, what are you going to do?
So we can start with 22.
14 French.
8 to 14 French.
Yeah. Smaller size, okay? 8 to 14 French. Yeah, 8 to 14 French, Seldinger technique, okay?
8 to 14, okay.
Fine bore, pigtail. Okay, what else will you do? Large pneumothorax?
I thought for the small we would go for 22.
22, 24.
Yeah, okay,
Four.
good.
I don't know. I would guess it only. Yeah, that would be
Okay, so there
guessing.
are two techniques of putting in chest drains. Okay, let me tell you this. One is called as a Seldinger technique, and the other one is a blunt dissection technique. Okay, so the size depends on what is the technique that you're going to use. If you're going to use Seldinger, then all discussion is between 8 to 14. Okay, and 8 is also very pediatric sort of thing. 12 is the one which is the safest answer to give. If I was you in the exam, if you're talking about Seldinger for a pneumothorax, I would say 12 French. 12 to 14 French is good enough. If you're talking about a blunt dissection technique, I would say 20 French.
22.
Okay, for a pneumothorax. Is this clear?
Yes.
Okay. Then you come to the hemothorax and everything else. Then hemothorax, what will you put in? Empyema and hemothorax?
32.
28, 30.
28.
28.
32.
28.
Okay, all right. So this is actually from the UK guidelines, but this is not our standard practice. But you can say this. This is from the guidelines. Okay. So there's a Seldinger tube size on this side, 12 to 14 French, and this side is the blunt dissection. Okay, and 20 French is for pneumothorax usually, and for larger ones, they're talking about 24 French, but you're quite safe to say 28 to 32 French. Post-operative, we use 28 to 32 French. The physicians use 24 French. Okay? Does it make sense what I'm saying?
Yes, sir.
So
Yes.
this, my next slide will
Yes,
tell
sir.
you standard post-operative surgery
28.
is 28
32.
French. Empyema and hemothorax is 32 French. What is the largest size that is available? Kitun?
in 32.
36. 36.
36. 36 is the largest size available. Is 40 available? I have not seen a 40. Somebody said 40. Have you seen a 40?
No.
I'm confused. I'm not sure.
Have you seen a 40? I don't know. I don't remember seeing a 40.
No,
From what I know, the
I'm
largest
not sure,
available
I'm
is a
not
36.
If you are
Seen
confused,
one.
that
I
means
haven't
you're
seen
So
not.
in a surgical drain, the normal is 20 French. Okay. All right. Now tell me,
16.
are you happy so far so good?
Yes, sir.
No.
Seldinger
Yes,
is
sir.
8 to 14. A bigger one, there's 20, 24, 28, and 32. These are the numbers you have to remember. And there is no right, no wrong. There is no guideline which actually talks about one is better than the other. Okay? It's absolutely all right. Whatever is your clinical.
ले जाओ.
How do you do?
पानी दे दो.
What is the site for an ICD chest drain?
Site, it's better to be done in
Awake
the safe.
patient.
Triangle of safety.
Somebody else take it.
Triangle of safety.
Somebody take it. Who else wants to take it? Rishabh Kapoor, are you in? Do you want to take it? You don't have to. If somebody else wants to, I don't mind.
Triangle of safety.
Triangle of
Who
safety.
wants to take it? Come on, one new person. Give me an answer.
Neeta is there, sir.
Neeta, please take this. Site of ICD placement. Where do you place the ICD? In the ward. Where do you place the ICD? Neeta is not there. She's not coming in. Somebody else come in, man. Some different person. Arif, take it.
Sir, based on the etiology, if it's pneumothorax, I would like to put the drain in the mid clavicular line, second or third intercostal space, the tip directed towards the apex. And if it's a liquid content, that is hemothorax or pleural effusion or empyema, I would like to go through the angle of safety, which is fifth intercostal space, or mid-axillary line on the side of affected side.
Tell me the three borders of the triangle of safety.
The triangle of safety, the anterior border is found by the lateral margin of the pectoralis major. The inferior border is found by the superior margin of the fifth intercostal rib, and anterior margin of the latissimus dorsi is the other border.
Okay, what is the base?
The fifth intercostal.
Axilla.
The base is the triangle of safety, which is the relatively muscle-free area. It consists of the intercostal space and the intercostal muscles.
Okay, let's go through this again. Okay, everybody listen carefully, okay, and go slowly. So lateral border of latissimus dorsi, agreed? Everybody happy with this?
Yes, sir.
Yes, sir.
Pectoral groove, happy with this?
Yes, sir.
And fifth intercostal space, okay?
Yes.
Above
Yes,
the
sir.
fifth rib, above the sixth rib, agreed?
Yes, sir.
Yes, sir.
Okay, now this,
Yes, sir.
you cannot go wrong in the exam, okay? Please. It's just 3 lines. You have to know this. There is no other way out. And where is the apex of the triangle?
Base of
The
axilla.
axilla.
Base of axilla.
Base of axilla. Okay, that is correct. So this is the site. This is how you cite it. How would you cite an ICD? How would you cite an ICD? How do you decide where to put in the ICD?
Depending on the etiology.
Up. No,
Okay.
no. Upper border of lower limb.
Upper border of the lower. Yeah. But where do you, on the chest wall, how do you decide where to put in an ICD? He just
It
said
has to
something
be
about
The
pneumothorax
mid
and whatnot.
axillary.
Depending on
But
etiology.
what do you have to do? What do you have to do?
no. I think that concept is out. That if it's a
Needle
pneumothorax, you have to put it
aspiration.
up, and if
Yes.
it's a hemothorax, you have to put down. I think that concept is gone now.
I
We
completely
have to
agree with
first
you. But
Tap.
confirm it with a needle aspiration.
before that, what do you have to do?
X-ray.
Position.
Position of the
Position
patient,
the
where you have
patient.
to, the same hand has to be
No.
up,
We are
hyper.
now. The patient is there, position in front of you. How do you decide where to put in the ICD? Come on, guys.
So we do
Ideally,
the
it's the
ultrasound.
X-ray. Confirm it again with an
Ultrasound examination.
ultrasound.
Thank you very much,
Ultrasound
Bhushan. Well
guidance.
done,
Yeah.
Bhushan. Very good. The answer is
Yes.
ultrasound. Okay. So this
Except for
concept
the
of second, third, seventh should not be said. You should just say that you have to do ultrasound, and on the basis of the ultrasound, we have to decide where the ICD is to be cited. That is the answer I want in an exam. Is that clear?
Yes.
Yeah. Is that clear to everybody? There is no
Yes,
details
sir.
about it.
Yes,
You
sir.
have to decide on the basis of an ultrasound where the ICD should be cited. Full stop. Is that okay?
Yes.
Yes, sir.
Yes, sir.
Yeah. And very rarely you might go in the anterior this thing, but nowadays this is almost given up. Most of us go in the fifth intercostal space, about the sixth. What are the positions for doing in an ICD? How do you place the patient? What are the three positions?
Patient is in the semi-recumbent position.
Okay, Vikas, come in. So one is semi-recumbent. Okay, what else?
Or patient is with a hand below the hand extended and abducted below the head. Otherwise, we can also put it in with patient sitting and bending forward with his hands resting on a table.
So give me three. I'll start again. Okay, Vikas, give me three positions.
I know only two positions, sir.
There are three positions, no?
Yeah. One is
You
supine.
said it, but you haven't told me.
Semi-recumbent
supine.
position.
Yeah,
One
supine,
is
semi-recumbent with the hand up below the head.
Yes.
Second
One
And
is
position
third
is
one.
lateral
Third one is
position.
Ek minute. Second position is what?
Sitting,
Vikas.
bending.
semi-recumbent.
We did that. He's supine. No, semi-recumbent and supine. You agree or not?
Yes, sir. Yes, sir. Yes,
Okay.
sir. Then patient
Supine,
sitting and bending forward.
semi-recumbent is the same position. What's the
Same,
second
yes,
position?
Patient sitting and bending forward with his hand resting over his
Second position. Good. What is the third position?
Lateral position.
Thank you very much. Okay. Now see, this is the thing. This is the reason why I brought a very, very easy topic to the platform, is because this should come bang, bang, bang. There should be no discussions on this. Could be this, could be that, could be nothing like that. It should come 1, 2, 3. These slides which I'm putting up for you are all guidelines. Okay. These are all coming from guidelines. You should be able to reproduce it straight away. There is no thinking about it. Okay. So I'm going to put, these are the three positions. You should tell me straight away. No thinking about it. Okay. Is that all right?
Yes,
Yeah.
Right.
Yes, sir.
There should be no hesitation in this, because this is exam going, and if you hesitate in all of this, you're wasting time for the bigger discussion. Okay. You never reach the bigger discussion. Okay. How do you monitor this patient?
We need to have at least pulse oximeter and ECG attached.
ECG and BP.
Pulse oximeter and ECG. Anything else you want to do?
BP monitor.
Maybe a
Blood
blood
pressure.
Non-invasive BP.
So you need a
Like
non-invasive
IV cannula also. Peripheral IV cannulation.
Yeah.
Yes.
Monitoring. We're talking about monitoring. Okay. So I like the IV cannulation. You must have a cannula, no doubt about it. But basic monitoring is pulse oximetry, respiratory rate, ECG, and a serial NIBP. It doesn't have to be a arterial line. Is it okay? Okay.
Yes,
Is this clear cut? So whenever I ask you a question of monitoring, you must give me 1, 2, 3, 4. That is the reason why I made these slides. Okay. These slides are made according to guidelines. 1, 2, 3, 4. No faffing about in the exam. Okay. Each one of you is thinking now, but this is something that you do every day. I want you to come with an answer. 1, 2, 3, 4. It might be sounding ridiculously simple, but you're not able to reproduce it for me. You understand? That's why I want to make sure that we talk about it and you have a visual image of what is needed. Okay, ICD tray, we know everything. Yeah, you should be able to identify every single structure on this tray. Okay, it is absolutely mandatory. If you don't identify something, I will be very upset. What is this?
Guide wire.
Come in,
Guide wire.
Fitun. Okay, guide wire. Fitun, come in. Somebody come in.
Yeah.
Fitun, Shilpa, anybody? Is Fitun
Yes.
still with us or no?
Yeah, I'm here, sir.
Okay, Fitun, I've given you this tray. Go from, I'll keep pointing, okay? And I want you to identify.
Okay, I just want to tell you, I've never seen a pigtail insertion.
Okay, so this is, okay, forget that. Somebody else take it then. Somebody else take it. Who wants to take it? Bhushan,
I'll
you
take
want to
some.
take it?
I can take it.
Who said I'll take?
Yeah,
Anuj.
take it.
I do.
Who said I'll take? Quickly.
Shilpa.
Take it.
Shilpa take it. Shilpa take. What are these two syringes for?
Liver lock 5 ml and 10 ml syringes.
For what?
One is for local and one
Well
is
done.
for
And what's the other one?
aspiration.
Well done. Stop.
Yes.
Stop. Don't do anything more. What are all these needles for?
Actually, I'm not able to see somehow the. What is it? Which
Doesn't
one you're
matter.
pointing?
Just there are two needles. What are the two needles for? You just told me the two syringes.
One is for local.
What are the two needles for?
Okay, one is for local and one is for aspiration. Just respected to the syringes.
Good. What is this?
So this is the one is a needle holder. Straight artery forceps.
Yeah, it's for dissection.
Straight artery forceps.
Yeah, what is
for
this?
dissection. Then it's 11 number blade.
No, what is this I'm pointing out? It's
BP
a
handle.
forceps. It's a forceps. It's a forceps.
Okay. Cover.
It's actually a forceps. What is this?
Okay.
Knife.
Knife. The
What blade do you use on this knife?
11 number.
11.
Okay. What is this?
Scissor.
Okay. What is this?
Tissue. So which one? Where is the arrow? So gauze
piece.
No, in front of the scissors. What is that?
Suture.
Suture material.
So my question to you is, what suture material do you use?
202.
It's either ethylone or silk, or at some centers they use proline also. The one with the very big.
What is the answer?
20 silk. 20
non-absorbable.
This is proline.
Even 20 nylon people use.
20 silk on a reverse cutting needle, 16 mm size.
Excellent. I like that.
Okay.
The answer I want to hear is a non-absorbable suture 20 on a reverse cutting needle. Okay, that's what I want to hear. And if you know 16 mm, it's even better. Okay. What is this?
This is the guide wire with the sheath of the guide wire.
Tell me two types of guide wires that are available.
The firm and the soft ones and the
firm ones. Very good.
firm.
Okay.
Yeah.
Excellent. Well done. What is this?
This is the Seldinger's needle, or the puncture needle.
Very good. What is this?
Dilator.
Excellent. Okay. Yeah. What is this?
This is the sheath of the. This is the sheath.
Yeah, and what is this?
And that is the
pigtail
catheter.
Pigtail catheter. Yeah.
Okay, thank you very much. Well done, Shilpa. You've identified. Now this is important. Okay, it sounds very stupid, but you'll be surprised the number of times people are not able to identify what is on the tray. Okay, so it is important you know every single item on the tray. You cannot make a mistake in this. And the one thing on the side here is a chest tube. Okay, you can't see it, but it's a chest tube. Okay, now somebody else come in. Who is going to come in? Is Vivek Mondal with us or no? Exam going, no? Vivek, yes, are you there? Exam yes, going. Vivek Mondal, tell me, yes, sir. Describe to me how you do a Seldinger technique.
Sir, should I start with consent and the...
No, just come to the technique because today is a lecture. So we just come to the technique.
So first we will do the positioning. Positioning is the patient is in a sitting position with his arms supported by a stool or to keep them flexed and abducted. And this will open the area where you want to insert the pigtail. Then secondly...
Vivek, we've done all that. Now come to the Seldinger technique, directly to the technique. You've given local anesthesia. You've prepared, painted, everything is done. Tell me the technique. I just want to hear the technique.
So first, the Seldinger's needle is connected to a syringe, and it is inserted in the desired intercostal space. Right. And as per the fluid is aspirated to confirm the entry into the space. It can be done with under ultrasound. Sorry, sir.
Tell me the direction of the needle.
The direction, sir. I don't know, sir.
45 degrees to the surface of the skin.
45 degrees to the surface of the skin. Okay. What part of the rib will you go through?
Sir, you go from the upper border of the lower rib.
Excellent. Excellent. Upper border of the lower rib. Then what do you do? You've aspirated. Then what do you do?
Yes, we have aspirated once we have confirmed the entry into a gush of fluid. After that, we insert the guide wire into the space. Once the guide wire is inserted, after that, the needle is.
How do you mount a guide wire? What do you mean by mounting a guide wire?
Sir, there is a small nozzle kind of a piece on the guide wire roll, which you put on the needle, which fixes it to it, which fixes. And
why is that device there? Why is that device present? Why
it will straighten the J-tip, sir. It straightens the J-tip.
Excellent. So you need to straighten the J-tip before you put it in. Excellent. Then what happens?
Then once the guide wire is inserted, you get the pull the needle out, taking care that the guide wire doesn't get pulled. And after that, you increase the skin incision, put the track dilators.
Excellent. I want you to understand this, that if you do not increase the skin incision, the track dilator will never go. No. You actually have to make a cut on the skin. Okay. Well done. What next?
Then once you go up to the desired dilator diameter, then you put the pigtail catheter onto the guide wire and insert it.
What is the intrapleural depth that you should go to?
So that actually has to be gauged with the ultrasound guidance, sir.
Yeah, but what is, and you should never try and go, should you go in 10 centimeters? Or what is the intrapleural depth that you have to be careful about?
Chest wall thickness?
Yeah, it depends on the chest wall thickness. I'm talking about the intrapleural depth. Intrapleural, how much should you go?
You should be the curve of the pigtail should actually go in. The whole of pigtail should go inside.
No, never more than 1 centimeter. That is what is the answer. Okay, never more than 1 centimeter.
Okay, sir.
The intrapleural depth should never be more than 1 centimeter. Otherwise, you will enter the lung inadvertently.
Okay.
Next.
Once we have done that, then we make sure.
Tell me how the pigtail will go on the guide wire.
Sir, you have to loosen the thread, which is taut, keeping the pigtail taut in order to make it straight. Okay. And once you guide it over onto the guide wire, then you have to hold the guide wire straight and then push the pigtail catheter in.
Absolutely correct. So you actually have to thread the guide wire through the pigtail, and you should not start entering the chest till the guide wire comes to the proximal end of the pigtail. Okay, that is the most important thing. The guide wire must come outside the pigtail before you start putting it into the chest. This is very important. Why?
Will kink otherwise inside.
Otherwise, the guide wire might go inside.
The guide wire is lost inside. Kinking is not the problem. The guide wire will be left inside. If you start pushing without the guide wire coming out on the other side and somebody holding the guide wire, then you will lose the guide wire into the chest. Okay? All right. Well done. Well done, Vivek. Okay. So what are the types of chest drains that you know?
Sir, can I ask a question now or later?
Yeah, sure. Pitun, this is an open discussion. Neeta, tell your kids to be quiet, whoever is in the background. Yeah, okay. Or switch off your thing. Yeah, come on.
When you put the pigtail, in which
Yeah.
condition you can put pigtail?
Usually when it's a fluid, and when you don't, in a small kid, you usually put pigtails. The physicians usually put in pigtails for pneumothorax. They put in pigtails for simple effusions, not for empyemas. There is a study which has said, which has looked, this was the UK study. It was a randomized control trial which looked at the size of the drain, and they have concluded that the size of the drain makes no difference. Hence, it's better to put in a pigtail. The guidelines, NICE guidelines, has picked up on that study. And so the first choice is always a pigtail when you are dealing with simple pneumothorax, simple effusion. Okay, so the first choice you should say is pigtail. Of course, if it comes to a surgeon, then we put in a chest drain. But usually, you should always say not a pigtail. I'm talking about a 12 French catheter.
I see. I see.
So a simple 12 French ICD is what you need to put in. And then if a radiologist is doing it, he will put in a pigtail. If a pulmonologist is doing it, he will put in a 12 French catheter, Seldinger catheter. And if a surgeon is doing it, he will put in 20 French or 28 French. Okay, this is how you decide. So what are the three types of chest drains that you, sorry, is there more?
I have one more question. Initially, you said only blunt dissection. Are you going to go through this?
No, we're going to talk about blunt dissection. That's later. At the moment, we're just doing basics.
Yeah.
Okay. What are the types of chest drains that you know?
Straight,
give me
right
all
angle.
Types. Good,
Straight, right
good.
angle.
One is straight, one is curved.
Right angle.
Very good. Yeah,
With trocar, without trocar.
Yeah. What's the problem?
Without trocar.
With trocar, there is more chance of injury to the underlying structures, lung and vessels.
What else? What other types do you know of chest drains?
Malicots
and the standard.
Okay. What else?
Pigtail.
Yeah. What else?
Indwelling pleural catheter.
Thank you very much.
Indwelling
catheters. Okay. So don't forget indwelling pleural catheters. So you've got curved drains, which are your standard drains or curved drains, whatever you want to use. And then more importantly, don't forget indwelling catheters, okay? Which is a pleurex drain for malignant effusion. Okay. So simple question, but you must know all the answers, okay, for this. It's not complex, but you must know all the answers for this. Okay, ICD, scrub. How do you scrub? What is the guideline for scrub? Anuj can take it if he wants.
Yes, sir. Just like standard surgical scrub, sir. Antiseptic hand wash with around 3 minutes of scrubbing up to the elbows with 7 steps of hand washing as recommended by WHO. And after that, donning of the gown and gloves with sterile technique.
No, we're still at scrub. We're still at
scrubbing complete. Okay.
What is your first wash? 4 minutes at the start of the day.
4 start of the day. Yes, sir. 3 minutes subsequent wash. Yes, sir.
Okay, so it has to be 1 minute per wash. Then you take the liquid again.
Liquid again. Yes, sir. Yes, 3 times.
So when you start, the first scrub has to be 4 minutes.
4 minutes.
First scrub of the day has to be 4 minutes. After that, every single should be 3 minutes.
3 minutes for subsequent.
This is guidelines, okay? This is
Yes,
from the guidelines.
We are following.
All right, okay. Thank you very much. Okay. Attire. Now, this is not the I'm sorry, the animation is not coming correct, okay? So the last word is coming first because I forgot to look at the animation. Okay, how do you gown up for a ICD?
I'm not going to say this.
To take the sterile gown, to place it on a sterile tray. Opening.
What do you have to
then
wear?
you put on.
Forget
it should be in
sterile
scrub
gloves,
OT.
okay? I'm sorry that's showing up.
Because it should be OT dress. It should be OT dress should be there. It should not be on the.
Okay, and if you don't have OT dress, what should you minimum wear? What are the recommendations?
So it should be shoes. I mean OT shoes, and it should not be a full sleeve shirt or something. You should be having
go on the
half
other
sleeves
side
folded.
go on the other side of the body. Shoes are good, but what's the other side of the body?
So cap and mask should be
Thank
there.
you very much.
Cap, mask, plastic apron and gloves.
Cap, mask, gloves.
Cap, mask. More
and gloves.
important than mask, what should be
cap
is there.
Eye protection.
Eye protection, yeah.
Eye protection. This is mandatory, okay? This is not recommend. This is not optional. These are mandatory. Sterile gown and sterile gown. Okay, this is mandatory. So don't think that you can just put in gloves and put in ICDs. It's not allowed. The guidelines have looked at it and they have said minimum required is a hat, a mask, an eye protection, sterile gown, and sterile gloves. Is this clear to everybody?
Yes, sir.
This is the answer I want in an exam. Okay. So you can talk about shoes and you can talk about slippers and you can talk about everything you like. But these 4 things is what I want to hear in the exam. Do you understand? My questions are very simple, but they are very relevant. This is what asked. Unfortunately, people don't come up with eye protection. You know, and in COVID-19 scenarios, it is very important to say these things. Okay? Because you're going to get exposed to intrapleural content. Do you understand this? So this is very important. Okay.
So if you're wearing spectacles, it is mandatory to have a mask with the shield, or is it?
Yes. Your spectacles are not designed to the eye.
Yes, sir.
You must have an eye shield or a face shield. When you wear a spectacle, you must have a face shield. That is the recommendation.
Why, sir?
Okay. Does it make sense?
Yes,
is it getting boring? Am I talking about very basic stuff?
No, sir. Not at all.
No, sir.
For all you guys.
Interesting, sir.
This has to be reproduced. For me, the most important thing is it has to be reproduced. It should come bang, 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 bang. Okay? All right, ICD preps. Again, I'm sorry about my animation. It's just gone haywire. What is the first thing that you use? What are the preps allowed? Somebody take it. Vivek, take it. Vivek, Sri Hari, take it.
Sir,
iodine and chlorhexidine. I'm okay with that.
Chlorhexidine, yes.
How do you prep?
Yes, sir.
How do you prep?
Sir, you'll paint from inside to outside in a either clockwise direction or...
Excellent. I like that. So always start at the site where you're going to put in and then paint in widening circles outside. The moment you touch the axilla or something, it has to be thrown away. What's the next thing?
That has to be done at least twice or thrice, sir.
Okay, that's all right. Yeah. What else?
And then you drape the patient, sir.
Before you drape the patient, what should you do?
Mark the site.
Wait for
it to dry.
The thing to dry. Okay. Otherwise, your drape will not stick. All right. So it's very important to wait for dry. Okay. And there is the recommendations. I've looked at everything. There is no recommendation of one antiseptic better than the other. But most of the people, they talk about chlorhexidine because people may have iodine allergy. Okay.
Yes, sir.
There is no recommendation or no specific site for no specific recommendation for any technique for site preparation. Okay. Again, I'm sorry the animation's gone haywire, but it's okay. I didn't check it, to be honest. So my fault. Okay. So far, so good.
Yes, sir.
Are you guys okay? It's a very simple thing, but it's important that you should be able to reproduce. Okay. How do you drape? Somebody take this. How do you drape? Who wants it? Ramaswamy, you can take it. How do you drape the patient?
Hello. Yeah.
Ramaswamy, take it. How do you drape the patient?
So the one drape is on the midline, sir. Anterior midline chest.
So what is you've got 4 drapes you're going to put, or you're going to put one drape with a large hole? All of that is allowed. If you have to put 4 drapes, which drape do you put first?
Lateral drape along the posterior axillary line, which covers the bed, separates the patient from the bed.
Away from you?
Towards me. Towards the person.
The first drape is towards.
Is always the one that's near you. Yes. Most important. The first drape should always be the one that's near you. Okay? And then you drape the other areas. Is that clear?
Yes, sir. Yes.
Okay. So I want to hear you say that the first drape should be always
the nearest,
close to the surgeon, and then everything else you put beyond it. Okay.
Okay.
But everything should be within his arm's reach. Okay.
Okay.
Does it make sense?
Yes, sir.
Yes.
Yeah. That fenestrated rape is not rape; it's drape. Okay. Sorry about that. Okay. All right. Thank you. What's the next step?
Anesthesia. Local anesthesia.
Thank you very much. So local anesthesia. Thank you. So make sure that you've got analgesia already loaded. Make sure you've got sedation and analgesia which has been decided. And should you use local anesthetic if you have sedated?
Yes, sir.
Yes, sir. Yes, sir.
Yes.
Always use local anesthetic irrespective of the level of sedation. Now, what is important? Is it the volume of the anesthetic that's important, or is it the strength of the anesthetic that's important?
Both things.
Both, sir.
Both are equally important.
It's volume
But
block.
if I gave you a choice of 2% lignocaine with adrenaline, 10 ml,
7.
listen to me. If I gave you a choice of 2% lignocaine with adrenaline 10 ml or 1% lignocaine with adrenaline 20 ml, what would you choose?
2%.
1%.
1%.
I'll choose 20%.
20 ml.
20 ml.
Volume block. It is volume block.
Okay, thank you very much. So,
20
do you understand my question? What I'm asking you is volume important or is the strength important?
Volume.
Volume
Yes.
block.
Absolutely correct. It's a volume block. The more volume you have, the more sites you can block, the more area you can block. The stronger the stuff, it doesn't make a difference because the block is going to be there irrespective whether you use 1% or 2%. Do you understand what I just said?
Yes.
Was it clear?
Yes, sir.
So
Yes, sir.
always,
Yes, sir.
even
Volume
if
is
you take,
important.
even if you take 2%, you double dilute it to make it 1%, but increase the volume. It is the volume that is important. You need more volume. So when you go, there is a whole chart of what drug you can use at what strength. You must know one or two of these drugs. Simple is lignocaine 3 milligrams per kilogram or lignocaine with adrenaline 7 milligrams. These are the two things you must know. Okay? Is it making sense what I'm saying?
Yes,
And
sir.
if you're
Yes.
given 2%, then you double dilute to 1% because it's the volume that you need rather than the strength when you're putting in an ICD. Does it
Yes,
make
sir.
sense?
Yes, sir.
Yes, sir.
Yes, sir.
Is it clear to everybody or no?
Yes.
Yes, sir.
Yes, sir.
Thank you very much. Okay. Now what are you going to do? You're about to give the anesthesia. What are you going to do?
I'll wait for 11
We'll
minutes.
tell the patient. We'll tell the patient.
Yeah, tell the patient.
Yeah. So do not touch it. These are all routine stuff. Okay. Make sure that the instruments are all available. And then you always inform the patient before you inject. And you inject. And then what do? Take the knife.
I'll wait for 10 minutes.
Yeah,
to check.
wait
Wait
for the
for
local
11
anesthetic
minutes.
to act.
To act.
That is a common mistake which all junior doctors do. They give the local and they reach for the blade. So you have to say in the exam, I will give the local anesthetic and I will wait for about 10 minutes. Okay? Or 5 minutes or 7. I don't care what time you wait. You have to wait
Should
and
act.
check
Till act.
for the anesthesia, whether it has acted or not acted. Does it make sense?
Yes, sir.
Yes, sir.
I have
Yes,
broken
sir.
down the whole, it's a very simple procedure. You do it every day. It takes you 5 minutes, 10 minutes to do it. But I've broken down everything into small, small parts so that you understand each part of it. And you do not falter in the exam at any part. Do you realize what I'm trying to do for you? Okay, now you've given the anesthesia. What do you do at this stage? In fact, even before you have done the anesthesia, you have actually painted and draped.
Arrange the
What are you
table.
going to do next?
Arrange the instruments.
Yeah, done. What are you going to do next before you start putting in incision or putting in anesthesia?
Marking the site.
To check the vitals.
How do you mark the side? You have got a sterile thing in front of you. How do you mark the side? How do you mark?
Ultrasound guidance.
Thank you very much.
Ultrasound
I'm going to
guidance.
use ultrasound. Thank you. So even before you give anesthesia, keep talking about ultrasound. Very important. And the ultrasound should be draped with a sterile cover.
Sterile cover.
Very
Sleeve.
important.
Sleeve.
ICD should be draped with a sterile sleeve.
Yes.
So it is real-time ultrasound. Should you actually mark it in the radiology room, put a mark and come and do the procedure?
The alcohol will rub it off the marker.
And what else?
Position changes
Position
the fluid.
may change.
Changes,
Collection may
yeah,
not be the same. Yeah.
because they might have done it in lying position, the mark, and you will do it in sitting position. That will change. So pre-marking is not recommended.
Not recommended.
Okay. So with ultrasound, you have to see the fluid. What else you see? What else you don't see? You use an ultrasound to see something and then to not see something before you go in. Yeah, okay. So you make sure that you see fluid and you don't see any lump
See other organ.
or any other organ. Okay. And at least 10 mm fluid thickness should be there. And How do you do the ultrasound? What? Just put it to the chest, or what do you do? What do you tell the patient to do?
Deep,
Hold the breath. Hold the breath.
deep breaths.
Yeah, so it should be whole
Hold the breath. Deep
respiratory
inspiration.
cycle, including
Yeah.
deep inspiration. You don't just put it to the chest and put in a chest drain. Okay? Does it make sense?
Yes, sir.
All right, Fitun, your answer is coming now. Tell me. Dissection. You kept asking me for dissection. So tell me, what do you do?
So if you go by blunt method or by sharp method?
What do you mean by sharp method? I don't know what is a sharp method. Tell me.
Method means using trocar.
Oh my God. Oh my
No?
God.
Okay.
Okay. My tip to everybody on this.
Knife.
We have got what, 32 people here or whatever, 40 people. Please, in the exam, do not talk about using an obturator. Okay? Do not. In the exam, everybody forget that there is something called as an obturator. Okay? Do not. Nobody likes the use of obturator. Proper thoracic surgeon should never use obturators. What happens because of an obturator?
Lung injury.
Okay, so injury happens. Now tell me in literature, what organs have been injured because of obturator? Just one by one, name them.
Lungs, heart,
Lung, intercostal
Heart,
vessels,
left
heart,
ventricle,
liver,
heart, liver, spleen.
all the organs.
Yeah.
diaphragm, stomach.
Stomach.
Okay, every single organ, esophagus. So every single organ that is there has been reported injured by the obturator. In the exam, you do what you like in your practice, I don't care. But in the exam, always say to the examiner, I will not use an obturator because there is a risk of organ damage, please. Okay. So don't talk about sharp dissections. Never. Very dangerous to do. Never do it. Okay. It's my advice to you guys. Okay. In my hospital, I don't allow anybody to use obturators. It's been taken off the stock because it's usually used by the most inexperienced person, and rest assured he is going to go through something. Okay. It keeps me in practice because I have to salvage the patient afterwards, but it's not good for the patient. Okay. So obturators are out. Tell me about dissection. So you start by putting the mark with an ultrasound. Then what do you do?
Then we start by, we use the blade to incise and reach only to the upper border of the rib.
Okay, good.
Only skin incision.
And then we use the arterial forceps.
Okay, what do you do?
To bluntly dissect it through the intercostal muscle.
Okay.
And then to penetrate the parietal pleura with the arterial forceps.
Okay, what should happen? Where is your hand when you are about to enter the pleura? The two hands. Give me the location of your two hands.
Okay, so one hand, the right. If you are a right-handed person, then the right hand should be holding the arterial forceps in a closed position, and then the tip of the arterial forceps would be resting on the index finger of the non-dominant hand, and it should be supported on the lower border, should be supported on the border of the rib.
What is the left hand doing? That's all. My question is, what is the left hand?
The left hand is fixing the tip of the arterial forceps, so it will be controlled penetration to the pleura.
Absolutely right. The left hand is the guard. Okay, the left hand is a guard against the skin. So you hold the instrument with your left hand to make sure you don't suddenly give way.
Yes.
Is this clear? So the right hand is dissecting, the left hand is the guard. It will guard against suddenly pushing into the pleural space. Does that make sense, what I just said?
Yes, sir.
Yes.
Yes.
Okay, thank you very much. Okay. So I don't mind whatever technique you want to describe, it's okay with me. This is how I would do this is actually a VATS procedure, but this is the same technique of giving local anesthetic. You have to aspirate as you go in and then just come out and make sure that you're injecting in the intercostal space. But when you inject, you have to aspirate before you inject. What is the problem with that?
Not going blood vessel. Not
Should
going
not
the blood.
inject lignocaine into
The
blood
blood. The
vessels.
blood.
What will happen?
Any blood vessel.
Arrest. Yeah.
What will happen? Arrhythmias.
Hypotension.
Lignocaine,
Arrhythmias.
arrhythmias, not hypotension,
Yeah.
arrhythmias.
Directly arrhythmia.
Hypotension
May
will
crash.
happen as a result of arrhythmias. So you should not do it because there will be arrhythmias. So you make your incision and then you do this dissection. I personally teach all my
Splitting.
juniors to use
Splitting.
instruments
Splitting.
rather than one instrument, and it has to be a splitting of the muscles
Splitting
rather
of the
than
muscle.
pushing
Splitting.
your instrument in. Can you see that?
Yes.
So it has to be splitting of the
Splitting the
muscles.
muscle.
Okay. So once you have see my left hand is the guard. Did you see that? Did you see my left hand was the
Yes, sir.
guard? I will show it again
Yes, sir.
if you want. The most important thing you should know how to describe this. Okay. So you have to talk. I usually use two instruments. If you got one, you can use one. It's not a problem. But my left hand is the guard. And then I dilate the intercostal space. Okay. All right. What is the next step after this? Fitun, what is the next step after this? You've just entered the pleura.
Yeah, so when you enter, you have to open the arterial forceps and keep it open
The
as a
tube ready.
dilatation, and then you rotate. You rotate, so you create an opening, Okay.
Okay. But what is the next step? The most critical step
The
now.
next step, then you take the chest drain with the other arterial forceps and you slide it over the opened arterial forceps, which is inside the pleural space. So that will be as a guide.
Okay.
Finger
Thank you,
dissection.
Fitun. Somebody else?
Finger
I want a
dissection,
different
sir.
answer.
Finger dissection, sir.
Finger. We have to
Finger
introduce
dissection. Finger
the
dissection.
right index finger. You need to introduce the
create a
right index
space.
finger
So-
and free the space of
Loculation to be
So
broken.
I want everybody
Yeah,
to
breaking
understand this.
loculations.
Okay. 1 minute. Wait. 1 minute.
Sir, if the
Go ahead,
patient
go
is on ventilator, to disconnect the ventilator.
Most important, patient has to be
yeah.
disconnected. Before you inject before you push into the pleura, if he's on ventilator, ask to disconnect the ventilator.
Disconnect him.
Enter the pleura, open your instrument wide to widen your space. But most important thing, before you put in any chest drain, you must put in your finger. Okay. This is almost a mandatory practice which I've taught everybody. Okay. Everybody has to do this. Why?
To
avoid the injury to the underlying lung and get rid of the
True.
adhesions, localized adhesions if there are any. So you have to get rid of them.
Okay. So you have to put a finger in. Please make it a practice.
Make sure it's
okay. Please make it a practice. Anything, whether it's fluid, air, whatever you're doing, do not push in a chest drain or do not push in a trocar or anything until and unless you put a finger into the chest space. Is that clear to everybody?
Yes, sir.
Yes, sir.
What is the advantage of the putting in the finger? Two advantages.
Sir,
One, you
tactile.
told me that you will get
Loculations
feel
and
touch.
feel of
You
the
break the
Feel of the
loculations.
organ. So solid or
First of all, the tract is made big.
Thank you. Well done.
Dilate.
Well done. You actually
Dilates
get an
and feel.
orientation of the tract.
direction.
Do you understand? When you put in a finger into that wound, you get a mental orientation of where is the tract. Your instrument going in could be 45 degrees, 60 degrees, 90 degrees. You don't know. And very often when you put in a chest drain, you find, a lot of people will have experienced this, that you can't find
Same
the
hole.
opening in the pleura.
Open.
You understand that?
Lost.
The reason why you cannot find the opening in the pleura is because you
Mental
don't
picture.
know what is the direction of the tract. And that is why putting in a finger gives you a mental picture of what is the direction of your tract. And then when your
Dilates.
artery forceps comes in with the intercostal drain, you follow the same direction that your finger has given you. Do you understand this? It's a very basic concept, but it does work.
Yes.
Many a times you struggle to find the pleural opening because your brain doesn't know what direction your instrument has gone in. Do you understand that? Is it clear?
Yes,
That
sir.
is why putting in a finger is very important. Okay. And then we spoke about Seldinger, so that's all right. So large bore, we said you must always do it. Please, please, please put in a finger. It is very important to do a finger thoracostomy. This you must say in the exam. You must sweep the finger to identify adhesions around the thoracostomy. And the other thing is when you put in, you hold the clamp between the tip of a artery forceps and push it in there. But the most important thing is it should be an unimpeded insertion. It should be, you should not get any resistance. What is the problem if you are getting resistance? What does it mean?
Either we are not in the correct plane.
Yeah.
Maybe we are different track. It may cause subcutaneous emphysema later or adhesions.
Could be
more
adhesions.
Importantly, what else? What else? More
Hitting the
important.
lung.
We are in the
Lung
lung.
is expanded.
We are in the
Yeah,
lung.
you are hitting an organ.
Wrong plane.
Got expanded
Hitting
already.
an organ. There is an organ in front of you which is stopping you from going in. Okay, so it should be unimpeded. Otherwise, anything that is stopping you, you just come out and put your finger in again. Okay, because you could be hitting the heart, you don't know that. So the last thing you want is to push the chest tube inside into the heart. Okay, never, ever, 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 ever use trocars. Okay, I want to clarify this to everybody. I don't care whether you do it or not in your practice, but good guidelines say you should not use trocars. It is actually banned in our hospital. We don't allow it. Is this okay?
Yes.
So far, so good. Is it making sense?
Yes.
You might have to stop if you want me to stop, okay, or go faster.
No.
But these are very important points which you need to learn. Okay. All right. Now, next, do not proceed with insertion if no fluid or air aspirated. Do not force guide wire if the drain is not moving well, and do not introduce dilators beyond 1 centimeter into pleural space. I told you earlier, okay, and do not use trocars. These are all important things, okay. All right, okay. So always aspirate pleural fluid before you go in. Always try to visualize the condensation inside the tube. It tells you you're in position. And always look at the drain position in relation to the skin. And don't forget about the marks on the drain. It will give you an idea of how deep you are in the chest. And don't forget about the holes. You have to make sure that every hole is in the chest. Nothing should be in the chest wall. Does it make sense?
Yes, sir.
Okay, so these things you have to read. This is very important. This is philosophy of safe insertion of ICD. What else? How do you make sure that things are okay? You can actually percuss the area. You look for percussion sound of suction. You look for improved gas exchange. You look for oscillation of fluid in the drain, and you look for bubbling of underwater seal. Does it make sense? Every single point is quite straightforward.
Yes, sir.
Nothing complex about this, okay? So this is the way you actually make sure that you're actually in there. What else? How do you make sure you're actually in the space? You've done all of that. Do you want me to just go back again? So you've done this, you've done this, you've done this, you've looked at this, you've done this. What is next?
Chest X-ray.
X-ray.
Thank you. God bless you. Chest X-ray. And what else can you make sure? How else can you make sure that your drain is in?
Column swing.
If we've done all that.
Improvement of the symptoms. Improvement of the symptoms.
We've done that. We looked at improved oxygenation. What else?
Ultrasound.
Thank you. You have an ultrasound probe in your hand. Okay, you have an ultrasound probe in your hand. So while you are there, just put the ultrasound and it will tell you that it is there. Okay? Does it make sense?
Yes, sir.
Very important. These are all very, 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 very basic questions. So, okay, thank you. Next question. What type of drainage valves do you have that you know of?
Underwater seal drain.
Somebody discuss with me drainage bottles, okay? So,
single bottle system.
Who wants to take this on? Who is talking?
I'll take it, sir.
Who is talking? Somebody said single water drainage.
Anuj.
Yeah, Anuj.
Just
Bolo. Talk.
So single bottle system, then double bottle and triple bottle.
Okay.
Then if it's a bottle, then we can
Anything
otherwise we can use Euro bag or something.
Triple bottle? Anything more than triple bottle?
There is.
Then digital.
No, 1 minute. Wait. My question is very straightforward, Anuj.
Yes, sir. More than
you said one bottle, I agreed.
2 bottles.
You said
yes,
two bottles, I agreed. You said 3 bottles, I agreed.
Yes, sir.
Anything more than 3 bottles?
Yes.
No bottle.
I don't know.
No bottle.
4 bottles. Okay, after 3 comes what? 4 bottles. Okay, so now we'll talk about all this. Okay. All right. After 3 comes 4, no? It's okay.
Yes,
so
sir.
4 bottles.
Yes,
okay. So let's talk about it in a minute. Okay. So you must always make sure that there is a one-way valve. That's what you want to make sure. Okay. So the valve should let stuff out and let nothing back in. Okay, that's the philosophy. We're talking about the philosophy of drains. Okay, so there are many different devices that are available. Let's just go one by one. Okay, let's look at underwater seal. Okay, now what is this system in front of you?
Single bottle system
Okay,
with underwater seal.
Okay, so what is happening here? Somebody explain this diagram to me.
So I will take, sir.
Who wants to take it? Who is it?
Anuj, I am taking, sir.
Take this diagram.
Yes, sir. So the bottle is having two tubes. Yes, sir.
Okay.
Just explaining the bottle first, sir. Bottle is having two tubes. One is open to air, which is not dipping inside the underwater seal, and the other tube, which is dipping inside the water, will be connected to the patient tube.
What is the problem of this?
So it can be, sir, wrongly connected. When we are connecting the tube, it may be get connected. Means people may by mistake connect to the tube which is not dipped inside the water. That may cause pneumothorax.
That's one. What else is wrong with this?
If it's a large effusion, sir, it will. We have to repeatedly change the bottles.
What else is wrong with this?
If there is a large water column, hydrostatic pressure will be high, so the pneumothorax will not get drained. If there is air or
underwater seal.
Good, I am agreeing with that. What else can you not do?
Attachment of suction cannot be done.
Yes, thank you very much.
You can't control the suction.
You cannot control. You attach the suction, you cannot control the suction because the suction will suck everything out. Okay, and it's not great. Okay, and more importantly, what is the risk of this single bottle system?
Pneumothorax.
No, more importantly, what is this fellow doing here?
So once patient inhales, that's
they can
If you inhale in water,
fluid can go back.
Fluid
can go back into the chest.
Level of the bottle above the bed
during inspiration.
So the disadvantage of a single bottle system is it is not efficient for draining large amount of fluid. It is not efficient for draining large amount of air. It is not efficient for using a suction system on it. And more importantly, it has a risk of the fluid going back into the chest. Does it make sense what I just said?
Yes,
this is the answer I want to hear in the exam. Okay. It's very simple, not complex, but this is the answer that I want to hear in the exam. So these are the advantages for it. Okay. It can be simple, cheap, can be done locally, pneumothorax. But the problems is not good for pleural effusion and also causes frothing. Okay, it causes frothing because the fluid and air are in the same bottle. So it causes a froth and you cannot understand how much is there. And fluid can go back into the chest. Okay, so that is one single chamber. Everybody understood single chamber underwater seal or not? Anybody got any doubts about it? Okay, so now somebody take this. Anybody can take it. I don't mind. Somebody else take it. Somebody different. Exam going people, come forward. Ramaswamy, you want to take it?
DNB exam going people.
Yeah, come
Vivek,
take it. Yeah, tell me what you see in front of you.
So this is the two bottle system where first bottle is the reservoir of fluid, and the second bottle is the underwater seal.
Okay, good. So what is the advantage and what is the disadvantage?
Sir, as we said, there is no admixture of air and fluid. Secondly, there is no effect of amount of fluid on the so even large amount of fluid can be drained without any effect on the underwater seal or without having any effect of because of the column of the fluid. And secondly, we can attach suction to this. And
what is the problem of attaching a suction in this? Is it effective?
Sir, it
you can attach. I agree with you.
It's less effective.
But the effectiveness
is less.
Yeah, it won't be effective.
Less volume of air
less
in
effective.
Yes.
first chamber.
Okay, so let me just go through it. Well done, Vivek. So there's a fixed underwater sea level. So you've got a separate area. There's low resistance to air. The fluid and the air are separated out in this. That's the most important thing. So there is no froth. Did you understand that? Is this clear?
Yes.
There is no air which is bubbling in here. When you see there is air bubbling in this one.
Second
This one there is air bubbling. Okay, whereas there is no air bubbling, so there is no froth formed in this. You understand that, as opposed to a single chamber. That's good. And then can be used for pneumothorax as well as for pleural effusion, because you've got a separate one for air and you've got a separate one for fluid. You agreed with that? The problem is it is less effective. It's less efficient at draining cavities. And the problem is the moment you put suction, the efficiency of the system goes down. Because you are, let me just bring it back up. Okay. So the moment you attach suction, all of this gets directly sucked into this and drainage of fluid goes down.
No.
Can you see that? Can you understand what I just said? The moment you attach suction here, this gets connected to this and it becomes like a single bottle drain. Did you understand that? This is very important to understand.
No,
that
no,
when
I
you
did not
the moment
understand.
you attach suction here, this
Negative pressure is
bypasses
more.
everything. So this is like one tube.
Negative pressure is more at the top.
The negative pressure is all in here and it directly, the efficacy of the suction goes down with 2 bottles. So what is the next level that you do?
3 bottles. 3
bottles. Thank you
3
very much.
chambers.
So, now somebody take this and explain to me why this is better than 2 chambers.
So because the first bottle is not in continuity with the last suction negative suction bottle.
Excellent. That is the important philosophy.
So it won't.
I don't know. Somebody said I didn't understand. Was that Shilpa you said that?
No.
Earlier somebody said I didn't understand.
Anuj.
Okay, 1 minute. Stop. Everybody stop. Pitun, did you understand why the 3rd bottle is now different from 2 bottles? Because
No,
the
I didn't
moment...
understand even the 2 bottles.
Yeah, second bottle.
Okay, let's go back there. Okay. So here, the reason why you put 2 bottles is because one is the fluid is collecting in a different chamber. Agreed? Happy with that?
Yes. Yes.
Okay. The problem is if you attach suction here, okay, this chamber is inefficient. This is gone. Because the suction will suck directly into this. And the efficacy of the suction goes down dramatically. And the third benefit of this is that this and this is not coming in touch with each other. So there is no frothing.
Yes.
Simple, okay? So that is why you add 1 more bottle, because when you attach 1 more bottle, you actually have a wall suction and you have a room air. Can you see this? This is different.
Yes, open.
Yes.
Did you understand? This is open to the air. So all the suction is transmitted, and fluid is coming here. So this becomes like a 2 bottle, but with a room air for venting.
Gentle pressure.
For venting your pressure. So you cannot go really high and suck the whole manga. Did you understand this or no? It's very important to understand these concepts. Yes or no?
Yes, sir.
Because see, this is sea level. This 2 centimeter is the sea level. This 2 centimeter is also sea level. But this gives you a vent for the suction. So you cannot oversuck the wounds.
Okay.
And none of this fluid will go back in the patient. Okay, the fluid there's a trap, there's a large trap. This air volume is quite large. It will not allow this fluid to go back. And none of this fluid can go back. None of this fluid can go back. If it goes, it will go from year to year. You'll have to sit and look at these 3 and apply your mind again to it. That's the only way you will understand it. Okay? Can I continue or do you want me to again go back?
Yes. Continue.
So this, you've understood the 1 bottle system. Where it is? Where is it? So we did 1 bottle. We understood what the problem with 1 bottle was. Then we did 2 bottles. And it's better than 1 bottle because fluid and air are coming separate. But again, suction is not giving you adequate efficacy. So we added a 3rd bottle to it. The 3rd bottle has a vent. Room air vent is the key.
Okay.
This is the key. This you cannot add that here because then your efficiency of suction goes to 0. Whereas if you have a 3rd bottle with this air fluid level, this adds the vent for the suction. And then this is what it is, okay? So you have a suction. This is the new things that you see. There are 3 chambers in
Chambers
this.
in the
This is
single
the
bottle.
this is 3 chambers. There's one from the patient where the fluid is coming, one air coming in here, and there is this one for venting the thing, and more importantly, there is room air venting. Can you see this room air going in here? This controls the suction. This chamber controls the suction. Oh, come on, don't do that. So this chamber allows you to control the suction by giving a vent. The most important thing is the room vent. Understood or not understood? I think you have not understood.
Understood.
I'm happy to spend more time, but so you can adjust the level of suction. It's very good for fluid as well as air, and importantly, fluid does not go back. So when I put up a picture of a 3-chamber, you should tell me these things. You should tell me that this is a 3-chamber system where fluid is collecting separately, air is collecting separately, and the suction can be vented. You can control the amount of suction that can be applied. If you, in a 2-chamber, if you apply too much suction, you'll suck out all the stuff, okay? So efficiency of a 2-chamber is not as good as efficiency of a 3-chamber. Did you understand or no?
Yes.
Yes, sir.
No, I don't think you've understood. I'm going to ask Kriti. Kriti, are you on here? You are the junior most in the whole group. Are you still there? No, Kriti is gone. Okay. So the bubbling in the 3rd chamber is what tells you. See this thing? Can you see this bubbling? This is what tells you whether your suction is working well or not. Okay? Yes or no?
Yes, sir. Yes.
This is the bubbling which tells you whether the suction is working well or not.
Yes.
This is the bubbling which is coming from the patient. This bubbling is coming from the patient. This bubbling is telling you whether the suction is working well or not from the atmosphere. Do you understand that? Yes or no?
Yes.
Sir.
Okay. So the problem here is the continuous bubbling from the 3rd chamber is irritant. It really irritates the patient, and it's very complex to set up. Okay. And there is no fail-safe method for suction failure. What do you do if the suction is completely clamped? It's a real problem. So they have come up with a 4th chamber where you have one extra thing in the 1st bottle. So if suction fails for whatever reason, this is it goes back to being 2 chambers.
2 chamber.
If this system fails for whatever reason, if there's a occlusion, there is a block or not good suction, then you don't want to make it into a tension pneumothorax. You understand that?
Yes, sir.
Hello? Have
Yes,
you
sir.
understood?
Yes, sir.
If the wall section fails, then it is a completely closed system.
Closed system.
Then you have a risk of a pneumothorax.
Pneumothorax.
Yes.
You agree or no?
Yes,
Right,
sir.
right. Very right. Very nice.
Did you understand that?
Yes.
Yes,
Yes.
sir.
I want
Have
you to
the
understand
opening
that.
to the room air? Why it would be closed?
No, it's
No,
inside
the room
water.
air is below
Inside
the water level.
Oh, okay. Yeah.
It is all coming here. The moment this closes off, this is all closed off.
Closed system.
Yeah.
So to make sure that failure of suction doesn't cause a tension pneumothorax, you have one system here which will overcome that. So this becomes a 2-bottle chamber.
2 bottle system.
Yes.
So whenever suction fails, this will become a 2-bottle chamber.
Yeah.
So the 4th bottle is called as a vent bottle. Vent. Safety vent. Clear or not clear?
Yes.
I'm sorry,
Yes,
you'll
sir.
have to sit with this and try to figure it out in your own head. Because the moment suction fails, it becomes one single chamber.
Closed.
And there is
chamber.
tension pneumothorax risk. That is why you have a vent chamber, which is a 4th chamber for venting the bottle. This is the understanding of 4 chambers, okay?
Yes.
So the 4th chamber is for vent, for suction control. So it's very, very important that you make sure that there are 4. So this is actually the atrium is a 4-chamber bottle.
Atrium.
Atrium is a 4-chamber bottle, and I drew all of this for you just so that you understand what is happening. Yes or no?
Yes, sir.
Yes, sir.
I'm sorry, I'm trying very hard. I know it is a little complex. But one chamber has a problem of frothing. One chamber has a problem of no suction. Two chambers separates the fluid and the air, but the efficacy of the suction is not very good. Three chambers gives you good efficacy with the suction, with a room air vent, but if it gets blocked, it becomes a single chamber and it becomes one long blocked system and you will get tension pneumothorax. So the fourth chamber is a vent which is added to the bottle to make sure that if any of this blocks, then you still have got air to escape out. Clear?
Yes.
I'm sorry, I took a little time, but it is important to understand this philosophy. Is it clear? Yes or no?
Yes, sir. Yes, sir.
I cannot proceed till I'm happy that everybody's understood what I'm saying. Okay, thank you. Now, what are the other suctions that you know of?
Digital suction.
Okay.
Digital suction.
So what is the concept? Somebody talk to me about digital suction. Bhushan, you can take it. Bhushan, did you understand what I said? Bhushan bhai, hai ki nahi hai?
Yes, I'm there.
Are you there?
Yeah.
Okay. Did you understand what I explained over 1, 2, 3, and 4 bottles?
Yes, that was atrium. Last
Okay.
thing.
The last is atrium. So it is the understanding how 1 bottle, 2 bottle, 3 bottle, and then 4th bottle. Okay. All right.
Yes.
Tell me about this, Bhushan. Tell me what you know about this.
This is a digital suction device, which is also called digital regulated suction device, specially made for chest. It is a gentle suction pressure device. It consists of tubings and a collection canister and a system which regulates the pressure within the canister. There is something called anti-frothing agent also inside the canister, and there is a non-written method, non-written flow back to the chest, also mechanism into this device.
Tell me advantages. Tell me disadvantages.
Advantages is it is a regulated, continuous, subtle suction device, especially made for the chest level pressures, intrapleural pressures, basically. And it is a portable device.
Excellent.
And, yeah.
What else?
You can adjust the pressures, and it also shows the amount of air leak. And
good.
yeah,
It gives you a graphic representation.
Graphical
It gives you a graphic representation of what is
You can record the graph also.
at that moment, and more importantly, it gives you a graphic representation of what is happening over 24 hours.
24 hours.
You understand that?
Yes.
So it helps you in decision making. So when you come on a ward round, it's not as if the nurse tell you, last night I saw a bubble.
Bubbles.
You know, it doesn't say that. It actually gives you a graph of exactly whether there was an air leak or no air leak, and what is the period between which that air leak has stopped. Do you understand that? Is it clear? So this is a very, very good device.
Yes.
It's excellent for continuous, sustained suction. If you are giving -2 kilopascals, it actually gives -2 kilopascals as opposed to the wall suction, which could be irregular. It is portable. It has got an inbuilt battery, which has a life of about 6 to 8 hours. And most importantly, it gives you a graphic representation of what is happening at that moment, and also gives you a representation of what has happened over the last 24 to 48 hours. You can actually go back and see the whole graph and on the spot decide whether the drain can come out or not. Does it make sense what I just said?
Yes, sir.
Yes,
Every
sir.
line
Yes.
of it is important.
Yes, sir.
So one
Tell
question,
me,
sir.
who's that?
So Anuj here,
Who is
sir.
it?
So is it a
Anuj, yeah.
double lumen? Is a double lumen tube, sir?
Yeah,
Yeah.
it has got
double
it's got
It's a
two
double
lumens
lumen.
to it. Yeah, there is two
Okay.
lumens.
Yeah.
One is for
Two lumens.
fluid and one is for the suction to be applied.
One
Suction
is for the
tube.
suction.
So
It
it's an
clears
inbuilt
keeps
suction.
clearing
Yeah.
it. Yeah.
Okay.
Yeah, it's an inbuilt system where one applies the suction and the second one gets the content out. One goes in, applies suction, second one allows the content to
It
come out.
has got an inbuilt
Now,
flushing mechanism.
yeah, it has got an inbuilt flushing mechanism as well, which flushes the system
Lot.
regularly. Okay. Now, give me a few questions. What did I want to ask? I forgot. What are the size of canisters available?
1 liter, 2 liter.
So 200 ml and 800 ml.
Yes.
800 ml,
800
1200
ml and 2 liters. 800
800
ml
and 2 liters. I agree.
ml,
It's available
800
as
and 200.
800 ml and 2 liters. Okay.
2 liters.
But different companies have different ones for their devices. What are the other devices that you know of? Shilpa, tell me other digital suction devices.
Atmos.
Okay, good. What else? Just give me names. I don't want details.
And this is Medela. This is Atmos.
Yeah, this is Topaz. Medela is name of the
Topaz.
name of the company is Medela.
Medela.
Atmos. What else?
Obedience has come up with
There's something of Digivent.
Airfix.
Digivent.
This is there in
Yes.
Australia. So there are a lot of these devices available. Okay. All right. Okay. So everybody happy with digital suction device?
Yes.
Okay. Now we come here. Okay,
Sir,
next
one
question.
doubt. Sir, Arif here.
Yeah.
Sir, you're saying constantly that the pressure should be regulated. It should not be. It should be minus 2 kilopascals. So what happens
Whatever.
if we?
No. It depends on
It's just
whatever.
example.
Different
So
surgeons
we
have
can
different levels.
we can kind of direct a post-op patient directly to the wall suction. Means, is that allowed?
Sorry, I didn't understand your question.
I mean, can we connect it to higher pressures? Can we connect the drains to higher pressures because to facilitate faster clearance?
You can connect whatever you like. You can make it -5, but not a good idea because it gives the patient a lot of pain and there is a risk of the lung tearing if you pull it up very aggressively. So over years of experience, almost everybody who does suctions stick with a -2 kilopascal. Some people do -1.5. Some people do -1. Nobody goes to -4 straight away. You do go to -4 when you have got an aggressive leak which is not being controlled or the patient is getting rapid surgical emphysema. Then you increase the suction to allow the lung to come up. But usually you will end up with putting in a second drain in that clinical situation. So -2 is a good answer to give. 2 kilopascals is the answer you have to give in an exam. But you can go whatever. It depends. Whatever is your comfort zone. But moment you go to -4, you're really sucking hard. Okay. -2 is the physiological pressure which measures the negative intrapleural pressure. So that is the comfort zone for the patient. Okay. What are the once you put in a chest drain? Okay, Fitun, come in again. I am a little. I want you to be happy. So Fitun, tell me, once you put in a chest drain, what do you put in? What do you do next?
After you put it, you mean?
Yeah, chest drain is in the chest. So what are you going to do? 2 things you need to do now.
So you have to fix it.
Excellent. You have to fix it.
Yeah.
So what sutures do you put around the wound before you put in the chest drain? I forgot to say you have to put in the stitch. Okay. Stitch should be put in before you put in the chest
Before put the tube.
Okay. Yeah, I forgot to say that.
Yes.
Yeah. So what stitches do you put in? Do you put in 1 stitch or 2 stitch?
It's better to put 2 stitch. So one for fixation and the other one for.
First, okay, I'm happy with that. I do a different way. I do 1 long stitch which forms a Roman sandal.
Fishnet.
Okay?
Fishnet.
But that's not important.
Can you
Good.
hear me?
I can hear you. Yeah, carry on. So you've tied the drain. What else do you need?
BTS guidelines specifically says you should not put circular and horizontal mattress sutures. First thing should not be
because it converts a horizontal wound into a circular wound and it causes ischemic necrosis and it causes pain. These are the reasons. But
the drain will fall, sir. But drain will fall.
The problem is that the drain falls out. So that is why the responsibility of ensuring that the drain stays.
BTS will handle it.
1 minute. The responsibility of ensuring that the drain stays in the pleura is the surgeon's.
Surgeons,
Okay,
yes, sir.
it is the surgeon's response. The person who puts in the drain must ensure
make
that the
sure
drain stays
fix it
in the
proper.
chest. Okay, so
Yes, sir.
that's why
Yes, sir.
you always, I
Put
personally
to
do not want to say that in the exam. It's okay. So what do? You put in an occlusive dressing. Okay, next. Once you've tied it, you have to put in an occlusive dressing.
Yes.
Covered dressing or transparent dressing?
It should be
Transparent if possible.
Yeah, if it's a
That's a
long-term
good
If
idea.
drain,
possible,
you
transparent. You can see the
then
holes
you need a
are.
transparent dressing
Good
so that the
idea.
wound can be assessed. Okay? Yeah, it's important. So if you know that this is going to be empyema for 5-10 days, then it's better to put a transparent dressing so that you can see the wound. Okay? All right.
Yeah.
Wound is sutured to close the skin, a pus string to hold the drain. Okay? If you have put in 2 drains, what are the precautions? Situn, you are pediatric
Yes, sir.
surgeon. Tell me.
No, I'm not a pediatric.
Yeah, pediatric cardiac surgery you do. So tell me.
No.
You have put in 2 drains. What is the precaution you have to take for 2 drains?
Lie or put the drains.
But would you put 2 drains like in a? That
No,
would
for
be
whatever
only in
reason. Say you
theater,
have
right?
put in 2 drains. Yeah. You put in 2 drains in theater. Okay, in your patient. What do you have to
Okay.
do to make sure? What do you have to do for 2 drains or 3 drains?
Place.
we must
Placement and marking. Marking of the drains, the placement,
What do
positioning.
you mean? What do you mean by marking of the drains?
we must put
One is a
identifier.
pike, one is
Anterior,
identifying
apically
identifiers of the
Absolutely. Absolutely. You have to label
Identifier.
it
label it,
separately
yeah.
and identify which is apical and which is basal on
basal.
the operating table. And it
Yes.
should be done by the surgeon who's putting in the drain. Why? Why is that important?
Apical is for air leaks, so basal.
No. What is the
So
importance
when
of labeling the drain?
So while removing the drain, decision
Thank
removing
you.
the drain.
Planning to remove.
Yeah. While removing the drain, if I tell you take out the apical and there is no
Remove other
mark
one.
on it,
Marking.
I promise you will take out the basal. Okay. So that's why it's important to label the drains. Multiple drains should be labeled individually. Okay. Now somebody can tell me how to connect a suction. Should you connect multiple bottles or should you connect one bottle? First question.
Ideally, separate section for separate bottles.
Ideally, separate bottles.
No, not suction. I'm talking about bottles. Forget the suction first. Forget the section. I'm talking about bottles.
Separate bottles. Separate bottles.
Separate bottles.
So in an exam, if somebody tells you that, say, I would like to connect separate bottles for separate
bottles.
That's the answer. Okay, I'd like to connect separate bottles for separate drains. Okay, because then you don't get mixed up and you don't know which is bubbling, which is not bubbling. So it's a good idea in thoracic surgery to connect separate bottles. That's first. The second thing is, can you actually use one suction for the 2 bottles if you're using wall suction, or do you need 2 separate suctions?
So 2 separate sections.
If you have
We can use one
Because
section
it'll suck
for
the
2
other
bottles. We need to
bottle
connect
inside.
both
One but 2 is
another
preferred.
bottle.
Actually, in most clinical
You can
scenarios,
use-
you're not going to have 2 suctions available on a bed space.
That's
So you
Y
Y
connector.
you Y connector, and you Y it and put the suction on the 2 bottles. So the suction
Other bottle
can be
fluid
one
comes-
suction,
One section.
Y, but bottle should be 2. Do you understand this concept?
Yes,
or
sir.
no?
Yes, sir. Yes,
Is it
sir.
making
Yes,
sense
sir.
what I'm saying?
Yes.
Yes,
Yes,
sir.
sir.
Yes.
All right. I'm sorry, this is very boring for you guys. Basic stuff. but
No,
it's
sir. No,
important.
sir.
All right.
Non-important topic.
All right. Somebody tell me
Can't miss
this.
on this.
No, it's good, sir. We're learning.
Tell me this. Tell me this.
Yes.
ICD
Somebody
sutures.
take it. Come on. What sutures you want to use?
Non-absorbable sutures.
Sir,
For
I'll take it,
long-standing,
sir.
depending.
Number 1,
Non-absorbable.
Reverse cutting
non-absorbable.
16
What is the
mm.
next word?
20
Next
Reverse
word.
cutting 16 millimeters. Yeah.
Eight minute.
Silk.
Stop. The first word is non-absorbable. Agreed. What is the second word?
20.
No.
Stitch
No.
suture.
What
Length
is
of
the
the
quality? We're talking about
Reverse
the quality
cutting.
of the suture.
Monofilament.
Stop. Monofilament. Thank
monofilament.
you. In an ideal world, you must use non-absorbable monofilament.
Monofilament.
Now, most of you use silk. That's okay. But why
That's
should
long.
you not use multifilament?
Infection.
Infection.
Absolutely right.
Infection.
The risk of infection with a multifilament suture is higher than with a monofilament. Did you understand this concept or no?
Yes.
Yes or no?
Yes, sir. So that means nylon or proline is better than silk, sir.
Absolutely correct. That is the in philosophy. Okay, in philosophy. If you're going to use it for a empyema drain, then ideally it should be non-absorbable monofilament. That is the key. If you're using it for surgical drain, which is going to come out in 1 day, it doesn't matter. You can use silk. But the philosophy of using a monofilament is that between the braided fibers of the multifilament, you get infection. The fibers, between the fibers, bugs can grow and you can get infection. So when you're using it in a long-term drain, it's better to use monofilament. If you're using it in a short-term drain for surgery, which is going to come out in 48 hours, it's okay to use silk. Do you understand that? Okay.
Yes, sir.
Yes, sir.
What sort of stitch do you put there?
One silk.
So
purse string should be what? What sort of purse string? If you do need to use purse string, it's a good idea to use a purse string.
Use figure of 8.
Yeah, figure of 8, horizontal.
Figure of 8, we are using
horizontal matrix.
Simple.
Okay, and then sorry for the last. Okay, so chest X-ray. Okay, you put in the chest drain, and of course we spoke about reverse cutting needle and all that. That's okay.
Yes.
Okay.
Why
You've
it
done a
has to
chest
be reverse
X-ray.
cutting?
It goes through better through the skin. It goes through better. The cutting is on the side of the skin, not on the inside, but on the outside. So it cuts through the skin. So a reverse cutting is always better when you're using this. When you're suturing an organ or something like that, you want the cutting inside. A reverse cutting is cutting on the outside. Okay? So it's a reverse cutting. So skin, it cuts through better. That's all. It's okay. You can use anything that you want. It's not a problem. Use a cutting needle. Just say use
cutting needle.
Yeah,
Sir, someone just said that purse strings are not in the BTS guidelines. Then
don't worry about it. That is actually for physicians. BTS guidelines for physicians. Okay? But most of us use purse strings. ESTS has said nothing about not having purse strings. Okay. So
anything about the stay suture?
No, nothing about the stay sutures. You can use 2 sutures. You can use 1 suture. It depends on whatever is your choice. Okay. All right. Chest X-ray. When should you do the chest X-ray?
Immediately.
After
2 hours.
Immediately.
After the
Depending on
procedure.
patient's condition. Depending on patient's
No,
condition.
depending upon the availability of the facility.
You want to see the
after the procedure.
Yeah, they want to check the position of the tube.
After the procedure.
Yeah.
Should be performed within 1 hour.
Yeah, that
The answer is it should be performed within 1 hour. Okay, stop. Don't argue amongst yourself. The answer is chest X-ray should be performed within 1 hour. Okay. How soon should it be reviewed according to guidelines?
As done.
Within 4 hours.
Within 4 hours, yeah.
Okay. You're not allowed to go see it next morning. The correct answer is as soon as it is done, but it will not be available. So if you're busy with other patients or whatever, you put in a chest strain, you've gone away, please return at least within 4 hours and review the chest X-ray. These numbers are outside limits, okay? These are not inside limits, okay? All right. Now, how do you make sure that the chest X-ray the drain is in the correct position on a chest X-ray?
So last hole we have to see. Is the last hole. Direction of the drain. Direction of the drain.
Direction
of the drain.
Thank you. Somebody said that. Who said that? Shilpa said that. The
radio opaque line is there.
You have to see that the radio opaque line is all inside the chest. The last hole is inside the chest. And the drain should not be kinked. Okay? And preferably on table, make sure that the drain is not lying in the
fissure.
Okay? All right. Next. How do you ensure adequacy of drainage?
So on X-ray wise, lung is expanded.
I'm sorry about the animation again.
So column movement.
Drainage.
No. How do you ensure? What should you do? Pleural fluid, chest full of fluid, 5 liters in the chest. How do you make sure? What should you do, man?
We should not drain more than 1,500 ml at a time.
Well done.
At a time, other pulmonary reaction edema. Yeah.
So never drain
1.5.
1 to 1.5 maximum hourly. Okay, 1 liter is what most people do. Otherwise, you risk Re-expansion edema. What does the guidelines say about clamping?
Re-expansion edema.
What does the guidelines say about clamping? For fluid, huh? Should you clamp or should you not clamp?
Should clamp.
Should clamp. Control clamp.
Guideline says you should clamp for at least 15 minutes before continuing. Okay? All right. The guideline says you must clamp for 15 minutes before continuing. And hemothorax 100 ml per hour for 3 hours is a problem. Okay, you got to think about it. 100 ml per hour for 3 hours is a problem. Your antenna should be up. Okay. All right. What do you do? Okay, who's next? Who's in there? Ramaswamy, come in again. You're very quiet. Are you back in, Ramaswamy?
Yes.
Is it boring or is it okay?
No, sir. I'm taking notes.
Okay, Ramaswamy, you're on the ward round and the drain has stopped bubbling.
Yeah.
What is happening? Why do you think the drain has stopped bubbling?
The tube could have been.
Give me 2 or 3 reasons.
Sir, either the lung has fully expanded. In case
well
of
done.
hemothorax.
Well done. Happy with that. I'm very happy with that.
Yes. Or the tube is kinked or blocked.
Excellent. What else?
Or the
No underwater.
Tube is connected to wrong bottle.
No underwater seal.
No, it was bubbling and then it stopped bubbling. So what is the problem?
Suction not
There's no underwater seal.
Somebody just said in the background. Who said that?
Suction not working, Nikhil.
Suction has become disconnected. Okay?
Yes.
These are the scenarios. Now, this is a very straightforward question. I will ask you in the exam. Okay? This is very straightforward. I want you to be able to answer 1, 2, 3. Bang, bang, bang. Okay? All right. Vivek, come in. Vivek Mundale.
Yes, sir.
Okay. Tell me.
So again,
can you see it? Can you see it?
Yes,
it's in front of you. Okay. So what's happened?
So again, this could be because the lung has completely expanded. Again, it could be because the tube has been blocked.
Okay.
Or the kinked and
Suction disconnected.
Suction is applied.
Suction is disconnected.
Suction is applied. Yeah.
No, I can't see.
Drain has come out.
The tube has become dislodged. Okay, tube has come out. All right. Okay, tube has come out and the swinging is lost because you are not intrapleural. And then the last one you said, lung is expanded. Okay? Is this clear? Happy with this?
Yes, sir.
Yes, sir.
Right.
Yes, sir, but sometimes
last one, sir,
on suction can stop.
Yeah, when the lung is re-expanded,
still
there is no
swing will reduce.
It will go away because it will push the drain against the lung, against the pleura, and all your holes are blocked. All your holes are blocked, no, when the lung re-expands. So these are the 3 answers. Okay.
Okay.
It's very all self-explanatory, nothing complex about it. Quite straightforward. Okay. Happy or not happy?
Yes, sir.
Happy.
Yes. Okay. So damage to local structures, we know all of these things. Okay. We know all these things. Just quickly look at it. Okay. I don't need to go through all of this. Lot of this. These are all reported in literature. Just go through it. Take a snapshot, and I'm okay with that. Okay. This is all reported in literature. Okay. All right. Okay. Tell me this. Somebody tell me what's happening.
So air decomplication and air complications.
During procedures.
Yeah. Okay. So we spoke about it.
Immediate or delayed.
Yeah, we've spoken about kinking, occlusion, clamping, causing pneumothorax. Agreed?
Yes, sir.
So far, so good?
Yes.
We spoke about dislodgement, which means it's coming to the subcutaneous tissue. And then post-pneumonectomy, you should not really put suction, okay? That's very dangerous. You should never put suction, okay? Okay.
Do you put chest
suction,
tube,
you always put chest tube, but don't apply them for suction.
Negative
clamp
suction.
them. You clamp a chest tube post-pneumonectomy, and every hour,
release
you
and
release
seal
it for 5 minutes just to make sure there is no bleeding.
Blood bleeding.
And if it is not bleeding, next morning you take the tube out, okay? All right. The problem with suction is it's a 2-edged sword, and one, it will keep the, it will allow the lung up, or it can keep the, either the alveolar leak patent, or if you've got a bronchopleural fistula, it will not allow the bronchopleural fistula to heal. Okay, because it sucks it open. All right. Re-expansion pulmonary edema we spoke about, and this is what it is. These are the various ones that are described, and what do you do in those things? So if there's dislodgement, you reinsert the tube. If there's re-expansion, you should not do that. You should get the patient propped up and clamp the drain, and patient might need CPAP. If you've got subcutaneous emphysema, then you've got to make sure that the side hole has not fallen out. Always give patient oxygenation. I don't like this. I'm completely against this infraclavicular holes and all that. Completely not to be done. And subcutaneous catheters, completely not to be done. Okay. This is from the guidelines which I read, but this is not done anymore. Okay. So these last two are out. You actually put in a second drain. That's what you have to do. Either you increase the suction on your existing drain, or you put in a second drain. That is the answer in the exam I want to hear. You find out that the drain is not in the subcutaneous tissue, you oxygenate the patient, and then you either increase the suction on your suction device, or you put in a second drain into another area so that enough air can come out. Okay. All right. Nerve injuries are fine.
Sir, one question, sir.
Yeah.
Sir, what is rationale for high FiO2 in subcutaneous emphysema, sir? So
they say that oxygenation allows the air to be absorbed in the subcutaneous tissue.
Air absorption. Yes.
Air absorption. It promotes air absorption when you give high FiO2. But don't talk in the exam about putting needles in the subcutaneous tissue or making cuts on the skin. These are not actually recommended nowadays. Okay, they're not spoken of. So best to say I'll put in a second chest tube, or I will increase the suction. Okay, these are two good answers to give. Okay, now somebody come in. Who has put in the chest drain? Somebody come in quickly. Come on, it's 7:15. Somebody come in quickly. Who wants to take the next question?
Yeah, Vivek.
Yeah, Vivek Mundale, take this. Come on, quickly. What documentation are you going to make?
Sir, I will document what size tube I have inserted.
Date and time.
Date, time.
Okay, sir, the notes. Okay, so date, time, and the procedure under what kind of anesthesia, and who has put the tube, who was my assistant, and who was the staff who had scrubbed. Then next, what tube was inserted, and
before that, what are you going to document?
Diagnosis.
No.
What came out?
Local anesthesia.
Position anesthesia.
Talk about the anesthesia given. You have to talk about the volume of anesthesia given. Okay, Vivek, continue. Vivek, you're doing very well. Just continue. What next?
Then yes, sir. Where on which side the drain was put? What size of the drain was put? What were the findings during the procedure? What came out? Was it air? Was it blood? Or was it fluid? Or how did the patient tolerate the procedure? And how have you clamped the ICD after the procedure or not? Then after that, yes.
Read the third line now. This is very important.
Type of tube inserted, including the serial number and barcode. Okay, sir.
That is a medical legal requirement nowadays. Okay. Any prosthesis that you put into the chest must have a documentation sticker which has to be stuck in the notes of the patient. Okay. This is something that you have to say in the exam. We like to hear this. That the serial number and the barcode from that from the wrapping of the chest tube will be inserted into the patient's notes. Very important. What else will you talk about? I agree with everything you're saying. What else will you talk about?
And what is the underwater? Is it connected to underwater seal, or have you attached suction? And okay, mode of fixation and
you have to talk about what suture material you use to fix the drain.
How you fix?
Okay, you have to talk about suture or locking mechanism. More importantly, for removal. The documentation has to be there. How to remove the, what is your strategy
Number
for
of sutures.
Is that clear? Does this make sense? Everything you said, I agree. But these
Yes,
are
sir.
specific things which are over and above what
Yes, sir.
you would think of.
Yes.
Okay.
Yeah. Yes.
So important. Get this. Please get this in your mind. This
Yes.
we in FRCS exams we like to make sure you are a safe surgeon. Okay. So we
Yes.
really want to make sure that you know how to document your procedure.
Absolutely.
Very important. Okay.
Yes, sir.
Happy
Okay.
with that?
Yes. Yes, sir.
Yes.
I'm going to move to the next one. How do you look? How do you survey the ICD on your war trans? Come on, somebody take it. Somebody jump in and take it. Nikhil, take it, man. How do you see?
How much amount of the fluid?
Nikhil. Because give Nikhil a chance.
The amount of fluid drainage, amount of air leak.
Okay, good.
Presence.
Good. Keep talking. Keep talking. I'm happy with everything you're saying. What else?
Nature of fluid.
Nature of fluid.
Okay.
Nature of fluid in the tubing rather than in a bag.
Okay. What else?
Then chest X-ray.
Fixation of tube.
Pain.
Check the
What do you want
fixation.
to see?
Yeah, it should
Come
not
on
be
a ward
infected.
round.
Fixation.
Come on a ward
Fix
round.
properly. No?
You look at the chest tube. You've seen the bubbling. You've seen the volume. What next?
Fixation of the tubes that you have to check.
Make
Fix
sure the patient
properly.
is okay, man.
Okay, saturation.
Make sure the patient is
Also we have to
okay.
see.
Yeah? Okay, thank you. So make sure the patient is okay, for God's sake. Okay? Look at the vital
The tube
parameters.
and
You agree or no?
yes, sir.
Yes, sir.
Yeah.
You agree or disagree?
The tube and
Yes, sir.
What else? What is the most important thing?
analgesia. Analgesia.
Yeah.
Entry and then
Okay.
X-ray.
Pain assessment.
Analgesia.
You agree, Nikhil, or you don't agree?
Agree, sir.
Thank you very much. Okay, so besides looking at the drain, don't forget the patient. That's the point I'm trying to make. Okay. Look at the TPR, BP, saturation, and pain assessment. Okay. This is what I want to hear in the exam. Thank you. Okay. Antibiotic prophylaxis. Should you give or not give?
Yes, sir.
Clean case.
Yes.
Definitely.
Anybody has any
Depends
other
upon
difference in opinion?
Normally, I've got blasted.
We are not doing.
Actually, if you look
Underlying
We are
at
not giving. We are not
histology,
giving.
it
yeah.
is not indicated.
We are
It's
not
not
giving
indicated according to the UK standards. But if you have to give, you can give a single dose, and if you have to give, you give for maximum 24 hours,
24 hours.
gram positive cover. Okay, this is the answer that you have to say. Okay, and early removal is mandatory to make sure you don't get empyema. Is that okay?
Even if it is
So far,
part
so good?
of trauma, sir? If you are
there are
putting chest
exceptions
drain, let's say
indicated.
for hemothorax.
Yeah, no.
Clean wound is not indicated.
If it's an unclean wound, then you have to give antibiotics.
That's
That's
for
different. Trauma is different. Trauma is unclean wound. You have to do that. When it's a clean wound, then you don't give antibiotics. In a routine setup, you don't do that. Okay. All right. ICD. When do you remove? When do you remove?
When it stops functioning.
Who was that? Good, Vivek. Take it.
Very good.
When it stops functioning, sir.
Okay. One. What else?
Second. Great.
Lungs.
Come on. This is exam.
Lung is full. Lung is fully expanded.
Okay.
Lung is expanded.
Lung is expanded.
Drainage is clear. No.
Yeah,
You want to
serous
remove
drain.
it if it is dislodged or malpositioned?
Of course.
So even before the pathology is removed, you have to remove it when it's dislodged or malpositioned or put in a second drain. Okay. Then the pathology is resolved. I agree with you. Okay. What else?
Clinical and
You're not expecting any other procedures to be done. On the day if you've got central line to be put in, don't take out the chest drain.
Yes.
May cause
Patient is on ventilator. Would you remove or would you wait?
No, you should not. You should try
Yeah,
not
you
to
should not
remove.
remove.
You should try not to remove. But of course,
Post-activation.
if it's a long-term ventilation, then you have to remove. Because you can't keep in a chest drain just because of ventilator. Okay?
Okay.
All right. Bubbling has ceased for at least several hours, preferably 24 hours.
After X-ray.
The BTS guidelines talks about less than 200 ml per day, but that has changed. We don't do that. Nowadays, it's almost up to 400, 450 is tolerated. Okay. Chest X-ray should confirm that the lung is satisfactorily expanded. Okay. And if you're using a digital suction device, you have to look at 0 to 30 ml. Okay. Happy with this? Straightforward.
Would you clamp it, sir? Would you clamp before removal?
No, do not clamp the drain.
Do not clamp.
Clamping is not a routine part
Tension
of
pneumothorax.
taking chest
Not
drain.
advised.
We'll talk about it. My next question is techniques. Okay, so we'll talk about it. So my first point there is clamping should not be done, not necessary. Okay, that's my point. So you don't really need to clamp. In fact, it is discouraged. We say that as surgeons, you should not clamp a drain before removing it. If the patient is stable, if the chest X-ray confirms there is no complete lung expansion, if there is no air leak, you take the drain out. That is the bottom line principle. Clamping has no real role.
How many hours? For pneumothorax, for how many hours?
Normally 24 hours is what we say. Normally 24 hours is a safe answer to give. Okay. For at least 24 hours is what we say. Okay. All right. So clamping is not necessary before this thing. Now, do you take the chest X-ray out in inspiration or expiration?
And inspiration.
At the end of deep
and
inspiration.
Deep inspiration and inspiration.
At the end of deep inspiration.
One person has to answer. Shilpa, take it.
We
Shilpa.
take it out at the end of the height of deep inspiration, or the height of, at the end of the height of inspiration.
Somebody else wants anything different?
Expiration, sir.
Excellent. See, that's the problem. It's actually not clear
Not
whether it's inspiration or expiration.
Guidelines say
No, just wait 1 minute, Shilpa. Wait, I'm coming. No, just wait. The data, the guidelines are there. They're coming. 1 minute. So actually, if you look at the literature, it's not clear whether it should be at inspiration or expiration. But the BTS guidelines say that it should come out at the end of the expiration and Valsalva maneuver. Okay, this is the guidelines. Okay, now what have you got to make sure when the drain has come out? Are you happy? Is anybody unhappy with this?
Sir.
Yes.
Are you unhappy? Shilpa, are you unhappy?
No, sir.
Yes, I'm happy. I'm happy. Yes. Yes.
What do you have to make sure when the drain comes out?
Just come out smoothly,
So
sir.
the drain has come out entirely, and
Excellent. Excellent. I like that. Make sure that the
Tip of the tip is intact.
Particularly when you're using a 12 French one, okay?
Yes.
Very important to make sure the tip is intact. Make sure that the purse string is adequately
Is,
tied.
yes.
Yeah, it's adequately tied. Make sure there's a closed dressing and mattress sutures if it's a large bore ICD, okay? So make sure that your purse string is adequately tied. In a digital suction device, how do you take it out? Bhushan, you know this, tell me.
Yeah, the suction should be on of this thing while removing the chest drain.
Okay, good. What
Yeah,
are
the
areas for
air, yeah, and air leak should be less than 30 ml per hour. And the graph, 12 to 24 hour graph should be somewhere flat line.
Okay.
For air leak.
Yeah.
That is what. Chest X-ray, clinical and radiological good lung expansion.
Good.
This thing. Yes.
And you take the drain out. Okay.
Take the drain.
There is some suggestion in literature where they talk about putting the medulla onto zero or gravity.
Yeah,
hold.
that is what.
But
Is it?
but that is not. There's still a lot of controversy over that. Okay, we don't really know. We don't know the answer for that. But most of us just take it out as it is. No, they are not in the guidelines at the moment. Okay. In fact, I am a member now of an international guidelines for ICD drainage. So we are still working on this. We don't know the answers for a lot of this. And these things I'm putting it because we are reading a lot of literature. We know what is out there. There's a lot of confusion. There is no right or wrong answer. If either or you give in the exam, I'm okay. When you talk about clamping chest drains, I get a little bit twitchy because if you clamp and there is air leak, you might cause a tension pneumothorax and things like that. So clamping is not a routine part of the thing. Now, the next two slides I put in because Fitun spoke to me about intrapleural fibrinolytics, okay? So I'll just tell you what is the literature out there for intrapleural fibrinolytics. It's been looked at extensively, hemothorax, loculated empyema, parapneumonic exudative effusion. A lot of people have published a lot of things. They have said there is advantage of avoiding an extra chest drain, prevents thoracotomy, possible for poor surgical this thing. But there is risk of failure of fibrinolysis, temperature elevation, pain, bleeding, and may require urgent surgical intervention. Okay, so these are a few things that you got to remember. In my clinical practice, I am very happy to do VATS straight away. So these two slides I put in just to tell you that literature is there for IPF, but I personally, as surgeons, we should not look down that road. We should look at surgery. Okay. Now, next question is to who wants to take it? These are the last few slides. Come on, quickly. Who wants to take this question? Fitun, you tell me. Who can put in a chest drain?
Anyone should, any doctor should know how to put chest drain.
Yeah, but who should put in a chest drain? According to guidelines.
Thoracic surgeon.
No.
According to NICE guidelines, who should put in a chest drain?
Even cardiothoracic surgeons.
Even cardiac or thoracic surgeon if available in hospital.
Cardiothoracic and thoracic.
Emergency doctor,
Emergency medical
trauma surgeon, or any surgeon or a person who's handling the trauma.
Why are you talking surgeon?
That's what any person handling trauma, like
ICU registrar.
Emergency doctor.
The one who diagnosed the condition.
Why? Pulmonologists are not good enough to put in chest drains?
Yes, that's what.
Emergency physician.
Anyone who diagnosed the condition.
Critical care team.
This is the problem. You guys don't think in a broader sense. Anybody who has undergone local clinical safety procedure standards certification is the one who is certified. You have to be certified to pass a chest drain in the Okay? LCPSA, LOCSIP and NATSIP. Do you know what is LOCSIP and NATSIP?
No.
National safety standards and local safety standards. They're very important for invasive procedures. NATSIP means National Safety Standards for Invasive Procedure, and LOCSIP is Local Safety Standards for Invasive Procedures. Remind me to do a talk on that one of these days, okay?
Yeah.
It's absolutely mandatory. It's very, very important to know what is LOCSIP and NATSIP. Because in the FRCS Viva, if you sit down in front of me, I might ask you, what are the LOCSIPs for taking a patient to theater? Okay, so you need to know this. So remind me, I've got a full talk on it, 10 minutes or so, but I will do it someday separately for you. But you've got to have LOCSIP. The guy should be, and more importantly, when we talk about competency, what are we talking about?
You can handle the complications also of the procedure.
And what else?
Diagnose the complication.
Diagnose.
When we're talking about competency, what else are we talking about? Competency in putting in the drain, is that what we're talking about?
No, anesthesia also, everything, whatever, whole procedure.
From the beginning of the procedure till the end, removal as well as the complications.
Completely the procedure.
And what else?
Documentation. You can legally document.
And what else? What one skill he must have before he should put in a chest drain? He should know how to use an ultrasound. Okay.
Ultrasound.
You must know how to use an ultrasound.
It's important than the surgeon.
That is there in the guidelines. Okay. So any Tom, Dick, and Harry shouldn't put in a chest drain. Somebody who can put an ultrasound to the chest wall is the guy who must put in a chest drain. Is this clear? Does it make sense what I'm saying?
Yes, sir.
Yes, sir.
So there has to be satisfactory theoretical knowledge. There has to be incremental procedure knowledge. That means you've got to have a logbook. You must have a logbook. Okay, you cannot just put in chest drains and say, I am expert. You must have a plural procedure training log. That is the requirement. Okay. Okay. Last slide, I think. Audit. Anybody wants to talk about it? Not IPF. Sorry, not IPF. This is ICD. Okay. Sorry, I forgot to change. It's not IPF. It's ICD. Take it. Somebody take it. The exam going guy, take it. Tell me. Should you do an audit or not do an audit?
Do the audit.
Yes, sir.
Audit is mandatory.
What do you log in an audit? If somebody's phone is making noise. Silpa, I think your phone is making too much noise. Switch off his speaker for a second. Yeah. Okay. What do you log in an audit?
Indication.
Yeah, good.
Emergency or elective ICD.
Yeah, good. So you should talk about the patient, the need for the ICD, why you did it, what else?
And what was the result of the means? Any complications were there?
Yeah, thank you. Important. In an audit, really complications should be logged. And once complications are logged, what should happen?
So it should be audited. Like, what was the reason? Is it a correctable cause or not a correctable cause?
No, but where does it go to?
Hospital
committee.
Hospital audit committee.
Thank you. It goes to the local
Audit
incident
committee.
managing committee.
Yeah.
Okay.
Yeah.
And then what else happens? If you've forgotten a guide wire in the chest, okay, by mistake you push the guide wire into the chest, that is an incident. Okay. Is it a significant
reporting.
incident?
Yes, sir.
Yes.
It's a very significant incident. So what should happen?
Incident.
You have reported
Incident
it to the
reporting.
local
Incident reporting.
Incident
And
report.
after that, where must it be discussed?
Hospital committee.
Audit meetings.
Audit
Committee.
Thank
meeting.
you,
Hospital
M&M.
audit
It's
meeting. Hospital audit meeting.
discussed in the M&M.
Morbidity meeting.
Okay.
Okay, it is mandatory that it should be discussed in M&M. Okay. Now, nobody in the world will take 2.5 hours on intercostal chest drain. Okay. Thank you very much, guys.
Thank you, sir.
Thank you, sir.
Thank you, sir.
All right. This is not a joke. We have really covered it inside out, but I think it was a select group of people, and I'm very happy that you guys came on because these
Very
are
important.
Okay. Okay. Any questions you want to ask or anything else you want to ask quickly?
Sir, hi. Sir, can you tell how to remove the drains in case of multiple drains post-operatively when we are using a negative digital suction drain? Like, do we clamp one drain and remove, or?
No. The clamping concept works only when you are worried that there is a small pneumothorax and you are missing it and it will restart. Okay. So the clamping concept is not acceptable for all practical purposes. And the modern philosophy of removal of chest drain is that if you've got two chest drains, they both come out together.
Okay.
Taking one out today and one out tomorrow is no longer acceptable. The old surgeons do it. They take one out and then take one out 24 hours later. But the real philosophy is if the pathology is resolved and the lung is expanded and there is no air leak and you're happy with the drainage and the chest x-ray confirms that the lung is fully expanded, you take both drains out because you do not need chest drains in a pleura if the pathology is resolved. Do you understand this philosophy? This is the
How about
modern
if one is
aggressive
draining and
philosophy.
one is not?
But old timers will say, no, take one out, take another out. You can do whatever you want. There is a lot of confusion, but nowadays almost everybody will take, if the pathology is resolved, the drain has no business to be there for 24 hours. In fact, most of us don't even put in two drains, if you know what I mean.
Okay.
So that's how you do this. But in an empyema, sometimes you put in two drains.
Yeah.
And then if you put in two drains, one drain goes to the apex, one drain goes to the base. So if the air leak has stopped, take out the apical drain first. And then the next day, if you're happy, you take out the basal drain. Do you understand this thought process?
Yes.
So it depends on where is the pathology. What are you putting in multiple drains for? And putting these drains on suction, you can come off suction and stay for a few hours and see how the patient is doing. And then you can take both drains out. Okay. But personally, the thought process has to change. If you read Alex Brunelli's papers, you will realize that, the concept is that the moment intrapleural pressure is reached and the lung has re-expanded, why is the drain there? And if the drain has to be there, then keep two drains. Why are you keeping one drain? Do you understand that? It's a philosophy that you have to change. But in the exam, a safe answer would be, if the lung is expanded, if it's for empyema, I'll take out the apical, make sure there's no air leak, make sure there's no fluid, and take out the basal next day. Okay, that's the answer in an exam. But if you're doing really well and you tell me that really the moment the pathology is resolved, chest x-ray shows expanded lung, patient is clinical well, I'll take the drains out, that is acceptable.
Yes, sir. Yes.
Do you understand the philosophy? I'm not trying to confuse you, but you have there has to be a principle behind what you're doing, rationale behind what you're doing. There is no randomized control trial which says that taking one drain out, then taking the next drain out is better than taking both drains out. But the thought process has to be there. Okay, so it depends on how confidently you come across to tell me your answer. Okay, any more questions?
One question. One question.
Yeah, who is it?
Anuj here, sir. Anuj here, sir.
Yeah, Anuj.
Sir, if a patient is a known case of recurrent spontaneous pneumothorax, but no pneumothorax at present, and he wants to air travel, then we are supposed to put an ICD, or if a minimal pneumothorax?
No. You cannot medically certify him for air travel.
Yes,
that is the answer. He should have surgical treatment.
Okay.
No doctor should medically certify him for air travel. Putting in a chest drain is a disaster.
This is not an option. Yes, sir.
It's not an option because you will go and cause a tension pneumothorax up there.
Yes, sir.
So if he's got recurrent pneumothorax, he is not medically fit to travel by air. That is the answer.
Yes, sir.
You've got to be very clear about it.
Yes, sir.
He's not fit to travel by. He should have either fixation, surgical fixation, and then he can travel by air. You should never sign a certificate with somebody who's got recurrent pneumothorax. Okay?
Yes.
All right. Anybody else? Any other questions?
Sir, one doubt, sir. Vivek here.
Yeah,
sir.
Vivek, go ahead.
Sir, suppose we are planning to discharge a patient with a chest drain with a flutter bag. Would it still make sense not to give him an antibiotic since it will be there for about a week or two like that?
Yeah, antibiotic prophylaxis, antibiotic use is very different from country to country, to be honest. In the Indian scenario, you actually do give antibiotics because you're worried about cross infection and all this, the environment. In the UK, we will be guided only by what the microbiologist tells us. If there is no clinical evidence of infection, the white cells are normal, the patient is afebrile, then it's very hard to justify giving antibiotics. The microbiologist comes down very hard on you. But to be really honest, in the Indian scenario, most of us give oral antibiotics and send them home. But in the UK scenario, we are not allowed to use antibiotics without microbiology consent. And there has to be a reason why we are giving it. But a foreign body in the chest for 7 days, I can convince any microbiologist to give antibiotics. So in the UK as well, I give oral antibiotics and send them home. Because the worst thing you want is empyema in the chest. You don't want that.
Yes, sir.
So that is the thought process behind this. Okay.
Thank you, sir.
Yeah. All right. Any more questions? Guys, you have no idea how lucky you are. Somebody discussing chest drain for 2 hours with you. Bloody hell. Nobody will go through so much step by step. Okay. All right.
One day you took some class and Shilpa sends me a message. How was the class? I sent it got over just now. So what? Did he take 2 classes? That was the message he sent.
No, the thing is, if you are teaching people, then it is your responsibility to make sure they understand. That is the whole idea. What is the point of doing all this and just giving you 30 slides and walking away? I mean, you have to understand what I'm saying. And my philosophy is that what you learn today, you're going to learn for life. This is going to stay with you for the rest of your life.
Yes, sir.
So from today to the next 40 years, you will never forget chest drain. I promise you this. Yeah. And if you do, you've got a recording to go back to. So that is why I take so much time and trouble to actually explain.
I never take notes while you are teaching. I go back, see you second time, then I take the notes.
I 100% take notes.
I am surprised that you actually see that big video all over again. I
never see the video. Till like date, I have not seen.
No. It is a strong recommendation to see the video second time.
See the video second time, yes.
Strong recommendation to attend the live class. Live class, everything goes inside the brain.
Let me
Actually, I